Perché non parla? Dr. Mirza, we cannot hear you. Please unmute yourself.
Yes.
Okay, now. Thanks.
Okay. So again, I would like to welcome all of you for this meeting. And first, in behalf of Executive Council and Scientific Organizing Committee, and would like to welcome all of you and Professor Lillian Koo, our President of Ifso, and all the participants. Professor Lillian Koo, she's a current President of Ifso, Senior Past President of Ifso Asian and Pacific, Senior Past President of Obesity Surgical Society of Australia and New Zealand, Senior Consultant Surgeon at Pilden Medical Center and Clinical Associate Professor at Pilden University of South Australia. She has been at the forefront along with her colleagues at the Adelaide Bariatric Center in developing a very effective multidisciplinary program. This is welcome in all language, all of you. I just want to say, since the beginning of this year, 2020, and the world faces the challenges and event, and most dangerous is the pandemic of COVID. But the world has been able to work together and limit the spread of this danger. We also did not give up, but we have continued our scientific activities and research, and today we affirm that science and work will not stop. One of the latest surprise of this year is the absence of Professor Scopenaro, the icon of bariatric surgery and the pioneer of modern science of bariatric surgery. On behalf of Ifso Menac chapter, we submit condolence to his family and the scientific and surgical committee, especially bariatric surgery. This is our Menac members. We started with 6, now we are almost 8 countries, including Egypt, Jordan, Kuwait, Lebanon, Saudi Arabia, Pakistan, Iraq. They are the last 2 members joined us, and United Arab Emirates. And we are hoping to get more members in our society. Again, I would like to thank you and welcome you again, and to remind you about our live second Ifso Menac meeting and fourth SMBS meeting and other society. We are still not sure whether we can do it in February 2020 or we may also delay it. Thank you very much and welcome.
Thank you, Khalid Gari. It is my pleasure to be with you, and it's a delight to join you with your Ifso Menac Virtual Congress today. It is also my pleasure to start off this session, which is a debate session, and it's on the revision of sleeve. And we have 4 esteemed faculty that's going to talk about what you can do after weight regain with the sleeve. It is my pleasure to introduce our 4 speakers. Firstly, we will have Dr. Ali Khamas from the UAE, who is the president of the Emirates Society of Metabolic and Bariatric Surgery. He's also the co-director of Dubai Residency Program of General Surgery and the chairman of Central Morbidity and Mortality Committee in the Dubai Health Authority. Dr. Khamas is going to talk about the OAGB as an ideal backup after weight regain. Then it's my pleasure also to introduce Dr. Hazem Al-Momami, also from the UAE. He started his surgical training in the United Kingdom. He won a traveling scholarship to Tokyo, where he learned his principles of laparoscopic gastric surgery and then became a fellow of the Royal College of Surgeons of England in 2013. And he's also a member of BOMS. And Dr. Hazem Momami is going to talk about being the Roux-en-Y as a follow-up operation following weight regain after a failure from sleeve. Our next speaker is Dr. Ahmed Bashir from Jordan. Dr. Bashir performed his surgical residency in the USA, followed by another resident, a fellowship at Fresno in California. Then he moved to Jordan to become the founder and director of Gastrointestinal, Bariatric, and Metabolic Center at the Jordan Hospital, where he's currently practicing minimal invasive surgery and bariatric surgery. He's also the former chairman of the Communication Committee of the Ifso Menac chapter and is the current president-elect of the Pan-Arab Society of Metabolic and Bariatric Surgery. And Dr. Bashir is going to talk about the DS being the gold standard. Last but not least, we have Dr. Alas Abbas from Egypt, who's a professor of surgery at the Ain Shams University of Cairo, Egypt, and is also the head of bariatric surgery at the AAMS University. He's also the president of the Egyptian Society of the Bariatric Surgeons. And Dr. Abbas will talk about the SADIs as technically easier and what would be probably a better operation after weight regain. So it's my pleasure to open this session, which is a debate session on what to do with the revision of sleeves.
All right, good evening, everybody, or good afternoon for some of you who are probably are located a bit later. And for us, for those of you who are listening listening to this lecture from Pakistan, I don't want to say good night, but I think it's a bit late. Anyway, we will talk. This is a debate that I was forced to face a challenging surgeon, and I want to make it as scientific as possible. We have a say in our culture that came from one of the greatest scholars, and he used to say, Al-Imam Shafi'i, he used to say, I wish every time I am in a debate that the other person will teach me the truth. So let's start this. This is my, I do a lot of one anastomosis gastric bypass. Around 30% of my, of what I do is sleeve gastrectomy. My Roux-en-Y gastric bypass experience is around 5%. So if we are talking about the best procedure for anything, a best procedure in bariatric need to be easy to perform, need to have minimal complication, need to be faster, and need to be have excellent weight loss. We should try not to have GERD post-op. The procedure should be as durable as possible, though we know that all procedure that we know up to date fails the test of time. A reversible procedure is usually better, and the less nutritional deficiencies that we can have in any bariatric procedure, the best or the better the procedure. If we define one anastomosis gastric bypass, we would think of that there's only one anastomosis. We would also think that there is a longer biliopancreatic limb and there is a long narrow pouch. This is what define a one anastomosis gastric bypass. And with that, the long pouch, the longer BPL, it shares these characteristic with SASI and SADI as the power of the operation. GERD probably is a subject of discussion. Roux-en-Y gastric bypass power that it has less GERD. But what do we call a Roux-en-Y gastric bypass that have a long biliopancreatic limb and a long pouch? Because I think this is what is needed when you have a failed sleeve gastrectomy. You need a longer biliopancreatic limb and you need a long pouch. But what if we make this with two anastomosis and a Roux-en-Y configuration? Are we talking a standard Roux-en-Y gastric bypass? Definitely not. Roy Rivero have called this procedure a diverted sorry, that's a mistake, a diverted one anastomosis gastric bypass. This is what he called it. This is a mistake from my side. So what options do we have for failed sleeve? Definitely re-sleeve is not for discussion anymore. Many surgeons have done this and this have failed a lot and in many hands. I've never done a re-sleeve because I've never believed in it. So what is left is one anastomosis gastric bypass, Roux-en-Y gastric bypass, SASI, and SADI. So how good is one anastomosis gastric bypass? These people have done a systematic review, and you can see that sleeve is prone to fail in 22% of people within the first 10 years. And this is a consensus of 70 expert bariatric that accepted one anastomosis gastric bypass as one of the procedures that can follow a failed sleeve gastrectomy. There's no doubt that one anastomosis gastric bypass offers excellent weight loss and early and mid-term follow-up. This group of researchers have looked and followed up their series of revisional surgery sleeve to one anastomosis gastric bypass, and they found excellent weight loss after the procedure, reaching 84%, which is amazing. Their GERD post-op de novo is 5 out of 70 something, like 2.5% only, which is amazing. This group of researchers led by Chevalier has reviewed excess weight loss and at 5 years and also the improvement of comorbidities, and you can see both has shown that one anastomosis gastric bypass is probably one of the best procedures, if not the best. Salman Sabah also has published, though this is an early result, but it is showing experience from within the MENA region. So there's more and more to show into this subject of excellent weight loss, and the only existing study that had failed to show an excellent weight loss is Bhandari's from India, where at 3 years the weight loss was not so significant, didn't even reach the nadir after sleeve gastrectomy, which I find it strange, but we cannot say anything about the researchers themselves. This is their research and this is their results. GERD after one anastomosis gastric bypass has reached in some publication 10%. Bile reflux also is one of the discussed controversial things. Chevalier has looked into this and has taken biopsies, and we could see in his result that this is not a big issue. What is our experience? We have had 19 patients that completed 3 or more years of one anastomosis gastric bypass after sleeve gastrectomy. The excess weight loss that we found is 61%. But we had a high number of GERD in our group, and we defined GERD by any patient who is reporting intake of PPI after the recommended 6 months. So if we compare one anastomosis gastric bypass to Roux-en-Y gastric bypass, for example, the standard Roux-en-Y gastric bypass, this is the result at 1 year comparing one anastomosis gastric bypass to SASI after sleeve, and you can see that the difference is sky high. These figures are from Tariq Mahdi group at Al Qasimi Hospital in UAE. So I don't want to go and dissect this subject more, because I think that it's clear to those who have done both procedure post-sleeve gastrectomy that one anastomosis gastric bypass is a very powerful procedure when we talk weight loss. Either we're talking about after sleeve or after lap band. It's a powerful procedure. In the field of GERD, there is some bad results actually, or I would say there's high incidence of GERD comparing primary one anastomosis gastric bypass and revisional one anastomosis gastric bypass. The GERD percentage are high. The need to convert to Roux-en-Y though is not so high. Most of them are controlled with one anastomosis with the PPI. That's what I wanted to say, and I thank you very much.
Good day, everyone. My name is Hazem Al-Momeni, and thank you for giving me the opportunity to talk to you today. It's been very unfortunate that we have not been able to meet in person. I've been tasked with the duty of talking to you today about the weight regain after laparoscopic sleeve gastrectomy and whether the one anastomosis gastric bypass or the Roux-en-Y gastric bypass is the ideal operation. This is my case mix disclosure. I've got no conflict of interest or disclosures to talk about. It's well known to all of us that the last couple of decades have seen the rise of laparoscopic sleeve gastrectomy. It's now the #1 performed operation worldwide. The reason being, it's a very easy, very safe operation. It's got a high turnover, and it seems to have a very good short to medium term weight loss. However, as the numbers of cases increase and the duration since we started doing this operation is getting longer and longer, we are getting some disappointing results about weight regain following laparoscopic sleeve gastrectomy on the long term. This brings us to the question of whether we should convert the sleeve gastrectomy to Roux-en-Y gastric bypass or to the one anastomosis gastric bypass. The Roux-en-Y gastric bypass has been around for several decades. We know its safety, profile. We know that it's a feasible operation, and the evidence has come around to prove that it provides adequate weight loss when converting the laparoscopic sleeve gastrectomy to the Roux-en-Y gastric bypass. The main other advantages of the Roux-en-Y gastric bypass is its versatility. It can be used with any other complications related to sleeve gastrectomy. It can be used to reduce the weight after weight regain from a sleeve gastrectomy, and should there be any problems related to the sleeve, be it a twist, a stenosis, or a sleeve migration, Roux-en-Y is the answer. The other advantages of the Roux-en-Y gastric bypass is that it can be used in the presence of any grade of esophagitis, whether it's de novo or whether it's developed as a complication of the laparoscopic sleeve gastrectomy. Also, and more importantly, it can be used in the presence of Barrett's esophagus. In fact, there has been some publications talking about the reversal of Barrett's esophagus in the absence of dysplasia when converting the laparoscopic sleeve gastrectomy to the Roux-en-Y gastric bypass. But what about the one anastomosis gastric bypass? As well, it is a safe and feasible operation. It seems to achieve an acceptable weight loss. However, when we look at the Ifso positional statement published in 2018, they believe that the one anastomosis gastric bypass, when performed as a secondary procedure, can achieve a weight loss which is at each point of time lower than the primary procedure. And we're talking here about long-term follow-ups. That's not the main issue related to the one anastomosis gastric bypass, because on the one hand, we've got an established procedure, the Roux-en-Y gastric bypass, with a long track record that validates its use for the many of surgeries. And in comparison, we've got the newer operation, the one anastomosis gastric bypass, which unfortunately is surrounded by many controversies. When we go to the history of the one anastomosis gastric bypass, we know all that it's based on the Mason bypass, publicized by Ed Mason at the end of the 1960s. Then it went away, be it based on quite a wide and a short pouch with secondary esophagitis, bowel reflux, and the well-known complications. Rutledge had managed to repopularize the procedure at the end of the century, and in 2001 had published his first series, calling it the mini gastric bypass because he's performed it through a mini laparotomy. In his operation, or on his take on the Mason bypass, he's managed to narrow the pouch and make it longer. Since then, the one anastomosis gastric bypass has become popular. It's the third commonest operation performed worldwide, and nevertheless, controversy still surrounds it. Until the date, it's still referred to by various names like the omega loop bypass, the one anastomosis bypass, or the mini gastric bypass. Recently, and at the beginning of this year, Ifso had established a consensus conference trying to negate the controversies and settle the controversies surrounding the one anastomosis gastric bypass. They've gathered around 50 experts from around the world with interest in the one anastomosis gastric bypass to try to get a consensus statement regarding this surgery and to try to standardize the procedure as much as possible. Having said that, this group of experts had managed to come up with several issues or complications related to the one anastomosis gastric bypass. Not to mention the uncontrolled gastroesophageal reflux disease, the protein calorie malnutrition, which unfortunately had taken the lives of several people with secondary malnutrition and liver failure. Then we talk about the anastomotic ulcerations and strictures, which are a well-known complication of the one anastomosis gastric bypass and the previous Mason bypass and the Billroth 2 reconfiguration. Then we talk about dyspepsia, alkaline gastritis, the gastric pouch rotation because of the length and the narrowness of the pouch, and then also a leak. In the Ifso consensus conference, all of these complications were offered to the panel of experts of nearly 50 surgeons from around the world. And when asked about what operation or what would your management be to control these complications, the answer was unanimously one. to convert the one anastomosis gastric bypass to a Roux-en-Y reconfiguration. So from my point of view, we've got a patient who's had a sleeve gastrectomy, had failed to lose weight. Ideally, we should offer them a Roux-en-Y gastric bypass rather than offering them the one anastomosis gastric bypass. While the one anastomosis gastric bypass is able to offer them a comparable weight loss, perhaps even metabolic control, however, it comes with several complications that might eventually need them to have a third operation. So let's cut the middleman and convert the sleeve gastrectomy to the Roux-en-Y gastric bypass rather than using the one anastomosis gastric bypass. One last thing I would like to mention to those people considering the use of the one anastomosis gastric bypass. In 2018, the ASMBS, the American Society for Metabolic and Bariatric Surgery, had done a literature review about the one anastomosis gastric bypass. Their review was favorable. They talk about good outcomes from the one anastomosis gastric bypass. However, they have raised concerns about the long-term follow-up following the one anastomosis gastric bypass. And they were keen not to endorse the one anastomosis gastric bypass as a recognizable operation. And that's due to the long-term nutritional deficiencies due to the hypoabsorptive patient nature of the operation and the issue related to the bowel reflux and the potential carcinogenic potential of the one anastomosis gastric bypass. A lot of people would say that the one anastomosis gastric bypass has been around for around 20 years. However, of those people who developed esophageal adenocarcinoma in public series, 5 of them had had a previous gastrectomy. And when we look at reason of the previous gastrectomy and find out that when the gastrectomy was originally performed for a benign reason, for example, weight loss, these 5% of patients would end up developing the adenocarcinoma after a long-term follow-up, and we're talking about 25 to 30 years, if not even more. The one anastomosis gastric bypass has been around for nearly 20 years. I think the upcoming decade will be able to answer lots of controversies related to this operation. This has been the end of my talk. Thank you very much for your attention, and I look forward to seeing you all in person in the very near future.
Good morning, good afternoon, good evening, wherever you are, and thank you to the Scientific and Organizing Committee for inviting me to deliver this talk on weight regain after sleeve gastrectomy. This is a debate with my friend and colleague, Dr. Ala Abbas, who has a vast experience in this field. My part is on duodenal switch being the gold standard. I offer duodenal switch to patients with BMI greater than 50, who ask for the best procedure for diabetes without reflux, and I offer it as a revisional procedure after sleeve gastrectomy. The term gold standard is a sensitive term to some. However, it's used and exists due to the monetary system that was present in the past, defining a fixed value of gold to determine a fixed value for the currency. This system is not used anymore since the 1930s. And whenever you look at the non-financial definition, it's a thing of superior quality which serves as a point of reference against which other things of its type may be compared. And it's mentioned in the bariatric literature greater than 290 times. So it's not a term that's going to go away anytime soon. So let's suggest the criteria for a procedure to be a gold standard. One is point of reference, superior outcomes with minimal risks, sustainability and reproducibility, and comparable outcomes when used as a revisional procedure. So if you look at post-pyloric bypass procedures, which DS belongs to, the first mention of any was Traverso and colleagues, pylorus preserving Whipple to prevent marginal ulcerations. Dr. Tom DeMeester and colleagues used it to treat bile reflux instead of Roux-en-Y gastric bypass to prevent marginal ulcerations and dumping seen in bypass. The first mention of any DS as a bariatric procedure was done by Lagacé, Picard, and Simon Marceau from the Quebec group, where they compared their DS experience non-divided and then divided to their previous BPD experience. They used a fixed elementary and common channel limb lengths. Meanwhile, we all know that Dr. Douglas Hiss was the first surgeon to perform a DS in 1988. However, his first report in the literature came 10 years later, 400+ cases, excellent weight loss outcomes, similar weight loss in patients with BMI greater than 50, and a low revision rate for excessive weight loss, diarrhea, or poor weight loss. And he attributed that to his use of percentages to determine the elementary and common channel limb lengths. He achieved an excellent death rate of 0.4% in an era of open bariatric surgery that had a higher mortality rate. The first laparoscopic DS was mentioned by Dr. Gagnier in 2000. From it came sleeve gastrectomy in 2004, while SADIs from Dr. Torres and Spanish group came in 2007. So the point of reference goes to DS for its earlier mention. On the outcome side, many reported their long-term outcomes. Dr. Michel Gagnier and Alphonse Pomp, 9 years experience, 77% excess weight loss, excellent remission from diabetes and dyslipidemia, and excellent improvement in quality of life, almost similar to the community norms in all facets. However, they had a high reoperation rate early, 12.4% with bowel obstruction. TPN need was still there, nutrition deficiency was high, reoperations was the highest, mainly for ventral hernias. However, bowel obstruction and pain was a reason for reoperation, and insufficient weight loss was seen in 11%. The Quebec group continued to compare their results to their earlier BPD experience. At 5 years, DS performed better, and at 10 years, it continued to perform better, and it had a lower revision rate due to malnutrition and insufficient weight loss, 4% compared to the BPD, 24%. Others published their similar outcomes to PAR, 10 years, the Quebec group, again in adolescents, 16 years, 20 years, all groups in the Quebec group, and Dr. Baltazar and colleagues published their 25 years experience. Excellent metabolic outcomes, almost complete remission from metabolic syndrome, and excellent long-term weight loss, 71% excess weight loss, and 20.2 drop in BMI points at 20 years. The Quebec group studied the resistant insulin type 2 diabetes and their 10-year remission rates. A strict definition of remission achieved in 68% of patients 10 years and beyond, and majority continued to enjoy that remission rate with a very low rate of relapse 6 years and beyond. However, SADI's 10-year plus data is not existent so far. The longest SADI's data came from Daniel Cottam group in Utah, 75% excess weight loss at 5 years, 35% total weight loss, short-term complications of 8%, including a death, 12% long-term complications, including internal hernia and hypoproteinemia. When they compared their earlier DS experience to SADIs, which they called SIPs at the time, DS performed better in the short term as far as weight loss. However, in their hands, the DS carried a higher complication rate short term and long term. Diarrhea and malnutrition was seen more in DS, while unique complications, constipation and retrograde filling was seen in SADIs more. This can be attributed to the small, maybe lesser experience in DS as opposed to SADIs. When Brazilians included a higher number of patients, similar weight loss, more patients, as I said, DS performed better in BMI greater than 55 in weight loss and diabetes remission. No difference in short-term outcomes. More nutritional deficiencies was seen in DS, more obstructions in DS. However, the numbers were low, 1.2% versus 0.6. More GERD was seen in SADIs. So an extra 2 points go to DS in superior outcomes and sustainability and reproducibility. The weakest point is revisions of sleeve long-term as far as the literature is concerned. This is a meta-analysis in 2019 that represents that. including only 47 patients to DS, 97 to SARIs, longer follow-up in DS, and better weight loss in DS. This meta-analysis did not include this excellent matched control trial from the Quebec group, comparing 3 groups of patients, 59 in each arm, sleeve gastrectomy versus second stage DS versus primary DS. Similar short-term complications, less long-term complications in second stage DS. And what's impressive is second stage DS caught up to primary DS within 5 years of their vision as far as weight loss, achieving similar remission rates from diabetes and metabolic outcomes. This in the best of hands as far as SARIs from the Spanish group. Whenever you do SARIs as a second stage for weight loss failure, patients achieve an extra 34.3% in excess weight loss, while BMI drops in less than 10 points. This was confirmed by this multi-institutional study that compared 2 groups of patients, one for sleeve gastrectomy failure, SARIs done after 46 months, while the group 2, SARIs planned 9 months after sleeve gastrectomy. And you can see the poorer weight loss in group 1, the sleeve gastrectomy failure, and the low BMI drop 8 points versus 12.2 in the planned group. So given those numbers, 1 more point goes to DS. With that, DS is the reference procedure with superior outcomes, thus it should be the gold standard. So I declare myself the winner in the debate. SARIs require 1 less anastomosis, thus DS carrying a higher potential for complications. However, this potential can be minimized in expert hands. And if you don't believe me, believe this expert panel of renowned bariatric surgeons who achieved consensus in DS being the preferred procedure by 97% of patients after sleeve gastrectomy failure, carrying superior outcomes, and they almost did not achieve consensus on this statement. SARI is a reasonable option to treat failed sleeve gastrectomy, 72.4% only. So with that, I thank you. Vote for DS and not SARIs.
Hello, my name is Professor Ala Abbas from Egypt, Cairo. I'm really honored to join the debate from the Ifso Menac chapter meeting Congress for the 2020. The topic will be revision of sleeve, weight regain after sleeve, the role of SADIs. This is my disclosure slide showing my case mix over the years with at least 20% revisions, and there where the most of the SADIS cases I have experienced lie, more than 45 cases. So sleeve is the commonest bariatric procedure for the last few years, and at any other bariatric procedures, it faces the problem of weight specificity or weight regain. To solve this problem, we have to think about where the sleeve came from. At the beginning, it was part of the duodenal switch operation, and it was a first stage for difficult cases to be followed up by continuing the rest of the operation. So sleeve revision lends itself to many other options, and that's one of its reasons for the popularity of the sleeves. So it's not only going to the duodenal switch, but other multiple procedures can be used as a revision. When we should decide to revise the sleeve by the SADIS procedure is for weight recidivism in patients who have no sleeve link or no strictures, no significant GERD, nor large hiatus hernias, probably super obese or high BMI before the primary sleeve, and for patients with metabolic relapse. We have gone a long way for the true malabsorptive operations, starting from 1997 by Professor Scopinaro, which was upgraded or changed to the duodenal switch in the 1988 by Dr. Hess, and in the 2000 or 1999 by the efforts of Michel Gagné, the duodenal switch was managed to be done laparoscopically, and the most recent modification of the true malabsorption operations in 2007 by Professor Torres and Bernotti, the SADIS procedure. So why we revise a sleeve weight regain by the duodenal switch is logic, because this was the original plan. Historically, we start with the sleeve and do the second step of the operation, especially in high BMI cases and high risk cases, knowing that the duodenal switch is the gold standard for its efficiency in giving satisfactory long-term weight loss results, especially as a revisional procedure. But what's against the duodenal switch is that it stood the test of time from the very beginning in the late 70s and up till very recently. It's been an unpopular operation. Only 2% per year in any given country in any given years for the last 20 years are the duodenal switch cases, and there are revisions or re-revisions. So there are problems with the duodenal switch which stopped its popularity, in spite of the fact that the well-known very good results, long-term good results of the procedure. And here comes a new modification, which was started about 12, 13 years ago by Dr. Torres and Bernotti, doing the single anastomosis duodenal switch, or the single anastomosis duodenal sleeve gastrectomy. And this is a schematic presentation of the procedure. So do we think that we shift from the duodenal switch to the SADIS because it's technically easier, as the title of my talk? I think the concept of having a technically easier operation is a good concept, but it's not enough to do an operation just because it's easier. But for the last 10 years, with repeated publications starting from Dr. Torres and many others followed, SADIS proved itself as a long-term good results as a revisional surgery after the sleeve. So it has excellent results of weight loss, similar to the duodenal switch, excellent results as regards metabolic re-remission after relapse after the sleeve, almost equal to the duodenal switch, but it has less complications, which is more important than the technically easier procedure, is having a procedure with less complications, especially nutritional complications and internal herniation, than the duodenal switch. So the SADIS is superior to the switch of having a common channel which is longer, 2.5 meters and sometimes 3 meters in a low BMI cases. It has almost no mesenteric windows, so internal hernias are almost absent or much less than the original duodenal switch configuration. And you cannot go through the dreaded Rho mistake during a single anastomosis procedure. And it also enjoys a shorter operating time and less difficult steps, so the incidence of intraoperative and early postoperative complication with a procedure which is having a shorter operative time and less difficult steps should be less. And managing the complications are also possible and much easier. So superiority of the SADIS is that it enjoys the popularity of the O1 anastomosis gastric bypass and avoiding many drawbacks. The main drawback of the O1 anastomosis gastric bypass of the bile regurg, because this procedure, the anastomosis is below the pyloric ring and pyloric sphincter. We still enjoy having that version field of dissection away from the previous sleeve and avoiding putting staplers on the previous area of the sleeve if you're going to change it to Rho-Y or one anastomosis gastric bypass. And it's well known that malabsorptive procedures are best for revision after a failed restrictive procedure, as Rho-Y gastric bypass have proved repeatedly being a very good procedure for treating GERD following restrictive operation, but not as good results of achieving good weight loss results in a failed previous procedure, restrictive one. These are some of the original publications, Bernotti and Torres, of the SADIS procedure, and this is another after follow 3 years. Across the ocean, Mr. Roslin also do the same procedure with a different name, calling it SIPES, his introduction and his, again, publication. And there's a recent publication, 2018, showing the superiority of the studies to the Roux-en-Y gastric bypass and showing remission of the diabetes, as you can see here, regarding the comparison between it and the Roux-en-Y gastric bypass hemoglobin 1.6, and it's quite clear that it's superior metabolically. In a cohort matched study also by Dr. Cotton, the outcome of the studies and the SIPES was very similar to the variable anti-diversion as regarding the weight loss results and the remission of the metabolic disease as a second procedure. Some people try to extend its scope of doing it with a fundoplication to include patients with GERD also. Most recently, the Ifso in 2018 has a position statement accepting the procedure, and they obviously wanted more longer-term follow-up to prove the procedure and bigger studies. And in 2020, the ASMBS also have accepted the SEDIS and SIPES procedure as a modification of the classic Roux-en-Y duodenal switch to be included and appropriate to metabolic bariatric surgical procedure. Again, they also wanted long-term safety and efficacy outcome to be studied and as still needed. So I conclude that we still need international registry for SEDIS and SIPES to make sure that the numbers are growing. We need long-term randomized controlled trials. And I think the rapid acceptance of surgeons and the spread of the procedure will prove that the SEDIS will replace the duodenal switch in the near future. Thanks.
Thank you. I think thank you for all the speakers for their presentation. I think Professor Lillian, you have some questions. If you can raise it, then we can comment about the presentations.
Yes, thank you. I truly enjoyed all the presentations. And we have some questions from the audience who have sent in their questions, and I'd like to refer to them. The first question is from Dr. Adel Rahman Nimari, and the question is to Dr. Bashir. How do you currently select when to do SADI and DS?
Thank you, Abdurrahman, for this excellent question. Thank you, Dr. Cal. As far as SADIs and DS, as a revisional procedure, reviewing the literature, DS is more powerful in weight loss as a revisional procedure and achieved better weight result outcomes, which is the most pressing point to a patient coming with weight regain. Now, when you look at SADIs and DS, yes, SADIs probably is gaining more popularity, similar to one anastomosis gaining more popularity compared to Roux-en-Y gastric bypass. It seems the intraostomy is a problem to many surgeons in DS and in Roux-en-Y gastric bypass. But when you look at weight loss outcomes, the perception is one anastomosis has a greater weight loss. DS has a greater weight loss, but the perception is higher complications. Now, in expert hands, in many publications, the Quebec group proved that the complications are similar, and we're looking forward to their randomized control trial, which is going to be published hopefully soon, comparing SADIs to DS after sleeve gastrectomy weight regain. For me, if the situation allows, I would do DS as a revisional procedure as opposed to SADIs, especially when you look at sleeve gastrectomy, not as a primary procedure, as a revisional procedure after gastric banding, let's say. Those patients have absolutely worse outcomes as opposed to sleeve being the primary procedure, especially in our experience. DS performed better in those patient populations. So for me, as a revisional procedure, I would choose DS being the more powerful operation.
Okay, thank you. I have another question here, which is from Dr. Gerardo Arredondo, asking this panel, what about vitamin deficiency, diarrhea, and reflux? Perhaps I could ask Dr. Ali Kamas to address that question with reference to vitamin deficiency, diarrhea, and reflux.
Dr. Kal, I think Dr. Hamas could not be with us due to his father being sick.
All right. Maybe Dr. Hazem Al-Mamani could answer that.
Well, in our part of the world, in the Middle East, bariatric surgery seems to have made good progress over the last few years. I think having fresh blood being pumped into the area, the adoption of standards from around the world had improved it. Vitamin deficiency does still to be a problem. This is one of the reasons I've got my reservations with regard to hypoabsorptive procedures like the SADI and the DS. However, similar to what Dr. Ahmad and Dr. Ala had done in their units, I think if you've managed to establish a very good, robust, multidisciplinary team where you choose your patients very well, you educate them, and you emphasize the importance that surgery or bariatric surgery is a life journey. It's a life decision. It's just not a one-off operation where you disappear and go. So regular follow-ups, continuous education by the surgeon and the MDT will play a big part. And I'm hoping that soon we'll be able to reciprocate the experience shared by Dr. Ala and Dr. Ahmed.
Okay. I have a question from Dr. Ashraf Hadab to Dr. Abbas. Dr. Abbas, do you believe that SADIs and DS have equal weight outcomes?
Obviously, this denal switch is a stronger procedure, and in the comparative studies applications, always the duodenal switch fares better as regards weight loss results. But the difference is not big, and the price is paid in always having more complications, nutritional complications, more internal hernias, and more revisional surgery for on the side of the duodenal switch.
Okay. I have another question from Dr. Ashok Puranik. What revisions do you recommend in sleeve patients with GERD? Maybe I'll ask Hazem to comment on that.
I think I would always say a gastric bypass. The gastric bypass, the Roux-en-Y gastric bypass, because as we said earlier, it's effective for all stages of esophagitis, regardless if it's mild, moderate, or severe. It controls the symptoms. It provides reasonably good weight loss. It might be not as comparable as the DS or the SADI. However, it does provide adequate weight loss. So my recommendation would be the Roux-en-Y gastric bypass.
May I comment about this because Ali Khamas is not here? You recommend gastric bypass. Many gastric bypass almost also can be used because you have long, narrow limb and will give you the same effect because most of the studies claiming that post-mini gastric bypass, the patient has bile. In some of these studies shows bile post-sleep, presence of bile in the stomach. So presence of the bile in the stomach, it's not. We are talking about symptomatic when the patient comes. If I do endoscopy for all patients, even what procedure, if you present, you can find bile. So we are talking about symptomatic. And symptomatic biliary gastritis or reflux with the mini gastric bypass, many studied symptomatic. which need treatment is very low, and these can be managed in the first appearance of the symptom by medical treatment for few weeks if improved. Only revision for this biliary reflux with mini gastric bypass, very little number, and only when it is failure of medical treatment. So I don't think there is a contraindication or absolute contraindication to do single anastomosis gastric bypass for patients suffering from GERD or sleep.
Right. Now, I have a question for Dr. Hazem. This is from Abdurrahman Nimeri, asking that if you have surgeons who do OAGB and have great results, why would they consider doing a Roux-en-Y gastric bypass, which is more difficult with an extra anastomosis and hence a perceived intraoperative difficulty?
Hazem, your mic is muted.
Sorry. I think that on the short and medium term, there is no problem with that statement. However, the concern is there's no doubt that the one anastomosis gastric bypass would provide good weight loss, will provide metabolically a good outcome. The worry was about, or the concern was about the long-term consequence. These patients, especially talking about the Middle East region, the majority of our patients are young people. They're in their 20s, 30s. They've got many years still to live. And the concern is what is going to happen later on. We know that compliance, follow-up or post-operative follow-up with regard to surveillance endoscopy, the pickup rate for that is quite low among surgeons and patients at the same time. So these are the main concerns. I think anyone who's got dexterity and the skills to do the one anastomosis gastric bypass should not have major difficulties learning to perform an extra anastomosis.
Okay, I have another question from Dr. Muhammad Al-Fayal, saying that erosive esophagitis will be developed in more than 10% of patients post Roux-en-Y gastric bypass. So what is your treatment in this option? So gastritis, erosive gastritis in Roux-en-Y gastric bypass.
So are we talking, I assume this will be in the pouch. The treatment would probably be medical to start with and see how the patient will do. The majority of these patients will do quite well. We need to look at their lifestyle, whether they're smokers or not, whether they're taking any medications that can contribute to this gastritis. I have not come across instances where we have not been able to sort this out. There is no doubt that this is based on the assumption that the Roux-en-Y was performed adequately. So we need a narrow and a short pouch. If you've got a large pouch, if you've got a high volume pouch, of a large capacity pouch, yes, there's a chance that these people can develop gastritis within that pouch. So if an adequately performed Roux-en-Y gastric bypass with lifestyle modification and medical treatment, we should be able to treat any potential gastritis that could develop there.
Great. And one question to anyone in the panel, do any one of you resize the sleeve before you decide on going on to a SADI or a DS or a Roux-en-Y gastric bypass?
Ahmad, I think you performed the virtual gastrography. Have you got any experience with that? Because I don't myself. I mean, we do the basic workup as in an upper GI study and an endoscopy and take it from there. But I think Ahmed had done some talks about this, which might be able to give us better insight.
Well, definitely those patients, you need all the data inputs that you can in order to perform the best procedure. Virtual gastrography is one of the things that we perform. If the sleeve is large at any point, fundus, antrum, yes, we do resize it because that may help additional restriction in those patients, help the habits early on.
Just may I comment? mini gastric bypass. Ali is not here. So again, the principle of single anastomosis gastric bypass based on the size of the pouch and length. So when we revise sleeve to mini gastric bypass, you have to check for the fundus, which is the most important, and you have to be sure that the size of the pouch be enough not to be complicated. We have seen many cases of the sleeve with a very big pouch up, so fundus. So you have to resize the pouch according to your tube size. So in single anastomosis, it is the key point for complication and weight loss is the size of the pouch plays a major. So in most of the cases, we have to review the pouch, and if we need to resize the fundus, we have to do it. Yes, I think you have to resize if you need.
So there are many, many more questions, but I think we can't answer all of those questions. We have run to the end of our time and even beyond. So I'd like to take this opportunity to thank the faculty and everyone, the panelists, for their time and also sharing their expertise with us.
Yeah.
Thank you very much.
Thank you all.
Thank you all very much.
Thank you all of you. Just to remind the audience that revisional surgery is not like a primary surgery, carries a more complication rate. Revisional surgery, you don't expect weight loss like primary surgery. There is still you have inadequate weight loss. You have to think about it. You have to think about also the vitamin deficiencies. Vitamin deficiencies can happen with all bariatric procedure with different ratio, but it is there. So it is not a big issue if you follow up the patient properly regarding the single anastomosis gastric bypass. When you revise sleeve to single, you have to consider the biliary limb. This is very important point in the revisional surgery. You know the biliary limb range from 150 up to 200. So you have to evaluate a patient properly and look for the cause of weight and inadequate weight loss and resize the pouch, and you have to consider longer biliary limb in revisional surgery than the primary surgery, so you will have the full power of weight loss. And again, we don't have standard operation, but for each patient, his own procedure would suit him based on your preoperative evaluation and look for the cause why patient not losing weight or inadequate loss or he gain weight. This is very important. Then you can select the right procedure for the right patient. Thank you for all speakers, and thank you, Professor Lillian. It was very nice being with you here today.
And it was my pleasure.
COVID-19 has changed a lot of things. The way we live, the way we work, the way we care for patients. One thing that hasn't changed is Ethicon's unwavering commitment to support nurses, doctors, and everyone who works for and with hospitals. We're looking towards the future and expanding virtual surgical training to educate doctors and clinical staff all over the world. We're focusing our portfolio on the tools that help surgeons and patients. Things like Plus antibacterial sutures, Dermabond Prineo, and Stratafix that help to reduce hospital stays, increase efficiency in the OR, and allow patients to recover at home. And we're accelerating new innovations, including remote wound monitoring. Every day brings challenges and opportunities. We're here, we're ready, and we're in this together. Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way, by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
Ladies and gentlemen, please take your seat. The session is going to start.
Hello, everybody. I want to welcome you to the second session about revision of sleeve part 2. Dr. Haysam Fawal and me, Gerhard Prager, will moderate this session, and we will have 2 battles. The first battle, or let's call it a battle, is reflux after sleeve. Roux-en-Y is the gold standard. Mohammed Al-Haddad will present. He's head of bariatric and metabolic surgery, consultant bariatric surgeon, master surgeon. He is also fellow of not only of the American College of Surgeons, but also of the Royal College of Surgeons in Ireland, Royal College of Physicians and Surgeons of Glasgow, and he furthermore holds a PhD in epidemiology and biostatistics. Osama Taha from Egypt is also a very, very experienced bariatric surgeon. He's member of the International Leadership for the Surgery of Obesity and Metabolic Diseases, member of the Swedish Research Group, and professor of surgery at Asyut University in Asyut, Egypt. And our second battle, Haysam, will be.
Thank you, Gerhard. I would like to welcome you all on behalf of the Scientific Organizing Committee of Ifso Menac. Our second battle will be between Salman al-Sabah. He is chair Department of Surgery at Jabal Ahmed Hospital. He is also the current president of GAS and the Kuwait Association of Surgeons. And with Professor Khalid Gautat, who is a professor of surgery at Ain al-Shams University. He is the founder and president of Egyptian Society of Bariatric Surgery. He is the president-elect of MENA. And of course, he is an excellent photographer. Gentlemen, the floor is yours.
Good afternoon, everybody, and thank you very much for the kind invitation for Ifso Menac Organizing Committee. I'm happy and honored to be here with all of you today. Thank you to my friend Ashraf. My name is Mohammed Haddad. I'm a bariatric surgeon working in Abu Dhabi in the United Arab Emirates. And I've been asked to talk about the reflex after sleep. Roux-en-Y is the gold standard. The debate against my friend Osama Taha, who believes with me that Roux-en-Y gastric bypass is the golden standard operation for reflux in all cases, not only after sleep. So this is my disclosure slide. I have nothing to disclose, and I will not be discussing any off-label use of any medication or any investigational intervention. And each surgical procedure has its own pros and cons, and it works well when used appropriately. Here's my disclosure slide. I do around one-third of the cases that I do are Roux-en-Y gastric bypass between revision and primary, and the rest are sleeve gastrectomy. So just to look at what's happening worldwide with bariatric surgery, according to the Angrisani study 2018, this is what's happening, around 700,000 operations. I'm sure it's more now. Probably this year, because of Corona, it will be less, but it's around 700 to 800,000 operations done worldwide. And sleeve gastrectomy is the most common operation performed worldwide. We know there is a big concern with the sleeve, with the reflux and Barrett's esophagus, especially after the studies from Italy and Finland. And we know also that Roux-en-Y gastric bypass is the standard operation whenever there is reflux, even in patient without bariatric surgery or who is not interested in bariatric surgery. One anastomosis gastric bypass has been another alternative in bariatric surgery because it was proposed to be less complicated, less potential risk of complication. However, the risk of bile reflux is a concern, and there are some modifications that were done on the procedure to reduce the incidence of reflux. However, we don't know if they work well. If we look into history, we know the history of the Roux-en-Y gastric bypass from Dr. Cesar Roux, which was proposed mainly to overcome the complications of the loop. We know that Dr. Mason and his contribution, and then Dr. Alan Whitgrove. If we look at the loop configuration in history, because looking at the history will tell us about the future, the present, and the future. So if we look at the loop configuration in the literatures, in the medical literature, we know that 25% of the patients will have postoperative symptoms, and 5% of them will have incidence of esophagitis and Barrett's, and it was a concern, and that's why Roux-en-Y gastric bypass was proposed to be the solution. And there is a late complication of development of stomach gastric cancer, which is associated with the bile reflux. And this is one of the arguments that I want to take today to discuss. So if we look at the scintigraphy of Roux-en-Y versus loop, if you look at the first picture upper, this is the Roux-en-Y gastric bypass, and you see there is no bile in the pouch. If you look at the loop configuration, you see how much bile in the stomach. So is that a problem? Yes, it is a problem. So what happens if we have bile in the stomach? There will be damage to the mucosa. There will be hypochlorhydria with bacterial colonization and secondary bile acid. Both of those will lead to atrophic gastritis and intestinal metaplasia, and might lead later to gastric stomach cancer. And this is the argument that is very important, because most of the proponents of the one anastomosis gastric bypass, they say that the bile is only in the stomach, it's not in the esophagus. So bile in the stomach is the problem, it's not only in the stomach. So what's happening? Is that in real life? So this study from Japan, they wanted to study the effect of bile acid reflux in the stomach and its relation to atrophic gastritis and intestinal metaplasia. They looked at more than 2,000 samples in 14 facilities, and they divided the concentration of bile in the stomach, as you see it, between 0 to 25, 26 to 50, 51 to 75, and they found there is a direct relationship between the increase in the concentration of bile and the incidence of metaplasia. So they concluded the high concentration of bile is associated with elevated risk of intestinal metaplasia. How about mini gastric bypass, or one anastomosis gastric bypass? This study from Finland, published in the obesity surgery, they studied 9 patients, and only 10 months after the surgery, they were able to do the scintigraphy in 8 patients, and they found that 62% of them, they have bile acids in the stomach, and that lasted almost for 1 hour in the stomach. So in one anastomosis gastric bypass, there is an incidence of bile reflux. We have to remember that the presence of bile in the stomach and the intake or interval between that presence of bile to the incidence of cancer, as you see it from the studies, from the literatures, it takes at least 17 up to 40 years to develop. So it is a problem. My friend Ashraf Haddad did this nice study where we sent a questionnaire to many surgeons in the Middle East, and we found that 32% of the surgeons in the Middle East, they did at least one operation for severe bile reflux after one anastomosis gastric bypass. Dr. Mario Mosella from Italy did a study, a multi-institutional study on more than 2,500 patients, and he found that there is the incidence of complications 3% in the early complication and late complication 10%, but most importantly, they found that the incidence of bile reflux or reflux gastritis after one anastomosis gastric bypass is directly associated with the presence of reflux in the pre-op period. Another study, a famous study, the Omega trial. I will not go into the detail of the Omega trial. Everybody knows about the results, but it's a multi-institutional randomized controlled trial where they compared 117 one anastomosis to 117 Roux-en-Y gastric bypass. As I said, I will not go through the results. I just want to show you that they scoped only 63 patients of the Roux-en-Y gastric bypass arm and 58% of the 58 patients of the one anastomosis arm, and they found that the incidence of esophagitis only 2 years after the surgery is 10%, and the incidence of gastritis is 12, and the metaplasia is 1, and they found that esophagitis also 12, and metaplasia is 1. So there is a significant incidence. How about revisional surgery when we do the one anastomosis? What's the revision? What's the most common cause? So this is again a multi-systematic review. They looked at 179 patients. 89 of them had a revision to Roux-en-Y gastric bypass, and the most common cause was malnutrition followed by bile reflux. So it is a problem for bile reflux after one anastomosis gastric bypass. How about when we use it, one anastomosis or Roux-en-Y as a remedy for insufficient weight loss? This study from Netherlands, a very nice study, 490 patients. They looked at one anastomosis versus Roux-en-Y, and they found that only after 2 years of the one anastomosis gastric bypass, 5.4% they needed a surgical intervention for reflux. So only after 2 years, almost 5.5% they needed a surgical intervention. So you can imagine how many of those patients had real, they have bile reflux, but didn't need surgery. Another study from France, they looked at the conversion of sleeve gastrectomy to one anastomosis gastric bypass, and they looked at 72 patients, a good number of patients. Only after 2 years, the incidence of reflux was around 13%. So it is a problem in the primary, it's a problem in the revision. So in summary, so what do we have? Just to make it simple, we're surgeons, we like simple thinking, and I'm one of them. We have a sleeve gastrectomy, we have bile reflux. So what do? We cut it from here, but we bring the bile up. That's what we do when we do one anastomosis gastric bypass. And bile in the stomach is a problem, bile in the esophagus is a problem. Versus we can do a Roux-en-Y gastric bypass where we cut it completely and divert the bile downstairs. So the take-home message, reflux after sleeve gastrectomy is a major concern. Bile in the stomach is associated with higher incidence of metaplasia and cancer. We have to remember there is a long latent period. So we're not expecting to see cancer after 3, 4, 5 years. As I showed you in the studies, it is problematic and it will happen 15 to 20 years after. One anastomosis after sleeve gastric bypass with reflux potentially can make the problem bigger. And I think my friend Usama agrees with me that Roux-en-Y gastric bypass is the only logical, durable solution for patients when they present with reflux and after sleeve gastrectomy. Thank you very much for the kind invitation, and hopefully I will be live and can answer some questions. Thank you.
Good evening, ladies and gentlemen. I'm so happy to be here in the Ifso Menac Virtual Congress 2020. And thanks for everyone who makes this comes true, beginning from Khalid Mirza, ending by the organizing and the scientific committee of this great Congress. I'm happy here to be with Mohammed, my friend, to debate about reflux after one anastomosis gastric bypass versus Roux-en-Y gastric bypass. So in 2012-13, in 2017 we reported our outcomes of omega loop gastric bypass after 6 years experience of 1,520 cases. And we found that in our series there is 0.3% of the patients suffering from anastomotic ulcers who has been treated medically and no one needs any intervention. And 41 patients out of this 1,520 cases, which is about 1%, suffered from intractable reflux. 5 out of the 41 patients needs surgical intervention just to dismantle and either to fix the ulcer or dismantle the one anastomosis gastric bypass and convert it to Roux-en-Y gastric bypass. Lee in 2012 in his very large series using the Jiggly score at 5 years post-operatively reported no significant difference between the one anastomosis gastric bypass and the Roux-en-Y gastric bypass in trapeze with heartburn. So both works for reflux. When we compare our study with the larger series in the literature about Lee, Kullar, Higa, Rutledge, Noon, Mosela, Chevalier, and Palmer, we found that our results are not that different when we compare it to other results. So in our studies about 0.2%, and Higa's studies 0.1%. The highest is Higa, which is 2%. Marginal ulceration, which is published from 2000 to 2017. In the meta-analysis of Kamal Mahawar, when we compare the results, so we found that Routledge in his largest series, 2,410 patients reported 4% marginal ulceration needed revision and 85% improvement in reflux. So in all primary one anastomosis gastric bypass and Roux-en-Y gastric bypass patients improved regarding reflux symptoms. Then yet actually the story differs when we go for the one anastomosis gastric bypass as a redo surgery. From May 2009 to December 2015, we have operated about 543 patients with failed restrictive bariatric procedures before. Underwent revisional bypass surgery. 348 of them were feasible for 2 years follow-up, are included in our study. 243 with we have redone them with single anastomosis gastric bypass. 105 we do the Roux-en-Y gastric bypass. Among them, 203 were failed after vertical banded gastroplasty, 95 were failed after gastric banding, and 50 after sleeve gastrectomy. And the demographic data, surgical parameters, and outcomes were studied. These are the demographic data of the patients. And when we come to the intractable reflux, we found a highly significant difference in patients suffering from intractable reflux when we use the one anastomosis gastric bypass as a redo surgery versus the Roux-en-Y gastric bypass. 60 patients out of 243 patients suffering from intractable reflux after single anastomosis gastric bypass versus 3 patients, which was 2.9% after a Roux-en-Y gastric bypass. So it's highly significantly different of patients suffering from intractable reflux when we use the one anastomosis gastric bypass as a redo surgery after failed restrictive procedures. We used the SS questionnaire, which is validated by Carlson in 1998, which is a nice questionnaire, and the final score for each symptom was obtained by multiplying the scores for severity and frequency. So the total score was obtained by adding the final score of individual symptoms and noted as a symptom score, or the SS. This is the questionnaire we used to try to figure out how many patients suffering from intractable reflux after one small gastric bypass versus Roux-en-Y gastric bypass. When we see this, when the score is more than 4, this means that it's considered positive for gastroesophageal reflux disease. So when we see this table, we will find that patients here with after one small gastric bypass is far more than patients underwent a Roux-en-Y gastric bypass. So if we see the total score more than 4, we will find it more in one small gastric bypass rather than Roux-en-Y gastric bypass. Then we studied it more and see how many patients after each procedure. So after vertical banding gastroplasty was the biggest winner. 28 cases out of out of these patients, 11 cases after adjustable gastric banding, and 3 cases after vertical sleeve gastrectomy. So when we use the one anastomosis gastric bypass as a redo surgery after each procedure, the biggest winner will be the vertical banding gastroplasty and suffering more, and comes after it the adjustable gastric banding, and the least patient suffering is who's doing the one small gastric bypass after sleeve gastrectomy. And as you see here, the number of patients complaining of GERD more than, when the score is more than 4, for patients who underwent one anastomosis gastric bypass, it increased with time. So the severity of symptoms does not decrease, it increased with time. We follow these patients for 24 months. And always the onset is not from the first month. The onset comes from the 3rd to the 7th month. And as you see here, patients of vertical banding gastroplasty suffered more than adjustable gastric banding and vertical sleeve gastrectomies. And it's comparable actually. When we dig into the literature, we will find Noon et al. In 2012. He reported by reflux of 4% of patients with revisional one small gastric bypass more than the de novo cases. In spite that the marginal acceleration numbers of patients in primary one small gastric bypass was more than 6 patients versus 0 in revisional surgery. So marginal acceleration may be less in revisional one small gastric bypass, yet the bireflux or the gastroesophageal reflux disease or heartburn will be more in revisional when we use the mini gastric bypass as a revisional surgery than a primary one. And this is a quick video how we resize the pouch and do the Roux-en-Y gastric bypass after sleeve gastrectomy. So this study actually has changed our practice for 2016. We like to go for Roux-en-Y gastric bypass or vertical sleeve gastrectomy rather than after rather than one small gastric bypass. So we depend on Roux-en-Y gastric bypass and redo surgery, and we do a distal long PPPL limb, biliopancreatic limb Roux-en-Y gastric bypass to achieve better results in weight loss in redo surgery, and patients are not suffering from gastroesophageal reflux. So to conclude, most of the literature study reported low incidence and no significant difference in gastrointestinal quality of life and symptoms of heartburn or regurgitation between primary one small gastric bypass and Roux-en-Y gastric bypass. So we can conclude that both are working well. Both are working well with in primary cases. And when we use the one smooth gastric bypass as a redo surgery, it has a better weight loss than the Roux-en-Y gastric bypass. It has a higher incidence of reflux and anemia and long-term follow-up. So regarding the reflux issue, one smooth gastric bypass as a redo surgery may be accepted after sleeve gastrectomy, yet we don't find it an ideal procedure after vertical banding gastroplasty and adjustable gastric banding. So we recommend to go for Roux-en-Y gastric bypass rather than one smooth gastric bypass in redo cases. Thank you so much for listening to me, and hope a successful Congress for you all. Thank you.
Hello, everyone. I hope everyone is well with this crisis. And I would like to take this opportunity to thank Ifso Menac chapter for the opportunity to present today. And thank you for having me. So this is Dr. Salman Al-Sabah. I'll be debating today with Professor Khalid Jawdat regarding sleeve gastrectomy long-term outcomes. So these are my disclosures. What's important in this photo, you can see my colleagues, especially Dr. Khalid Mirza, Professor Khalid Jawdat, and the rest of my colleagues. They're having this swords out, and basically they are pro gastric bypass. So it will be very challenging today to challenge them. So with that, I would like to move on with my case mix disclosure. This is, you can see it here. Now, laparoscopic sleeve gastrectomy have been over 20 years of existence, and it took from 1996 to 2006, pioneering period where modification happened. It started as a part of duodenal switch as a first stage or combined, and then what happened exactly in 2012, where we had the SEMBS recognize it as a primary procedure, and it was covered by the insurance in the USA. And during that period, we had the increased use of laparoscopic sleeve gastrectomy. From this Ifso Global Registry 2019, you can see sleeve became the most common procedure in the world. Especially if you look at our region, on the right side, you can see the MENA region, the most common procedure is laparoscopic sleeve gastrectomy, as well in the rest of the world. And this is for many reasons. And that's why it's very common procedure. Now, thinking about this debate, this comes to my mind using SWOT analysis. And basically looking at the strength of the sleeve gastrectomy, it's easy procedure, safe, durable, and effective. And I will show you all the data that support that. In terms of weaknesses, people speak about GERD and weight regain. However, we'll show if that happened, how we can deal with it with sleeve gastrectomy. Opportunities, it could be easily converted to any other procedure to add more weight loss or to help with the GERD. Now, we can add, for example, LINX procedure, phobia ring, cardiopexy to mitigate whether reflux or weight regain. Also now, the new technique with endoluminal procedure, also readjust or sleeve the patient from the inside endoluminally. And of course, you know about Apollo endoluminal procedure, endostitch. Also, sleeve gastrectomy, another opportunity is it can be done as a day case procedure in selected patients. Now, the threats are gastric plication. Gastric plication came a few years ago, and it came, the whole idea, it was supposed to kill the sleeve, but what happened, it's the other way around. And same as with gastric band, now it's this common procedure done worldwide. And however, single anastomosis gastric bypass and Roux-en-Y gastric bypass remain a threat to the sleeve. Now, we are surgeons, we are lucky to have all this kind of tools to help us to fight obesity. However, I'm going to show you now also what makes sleeve a better procedure. Now, looking at learning curve, we can see sleeve gastrectomy takes 68 cases only versus 102 with a gastric bypass. All procedures with bariatric surgery, with time, it became even showing less morbidity and mortality. And that's because of the learning that we had during this period and implementing programs that helped us to reduce mortality and morbidity. And now looking at the data from those publications, especially from the American College of Surgeons, it showed on these publications that sleeve gastrectomy has the lowest morbidity and mortality compared to the rest of the bariatric procedures. In terms of long-term outcomes, long-term outcomes, we're thinking about defined as 5 years or more. And so people divide them to more than 5 years, 5 to 10 years, more than 10 years. So I'm going to go over those periods and to show and prove to you that sleeve gastrectomy still has good long-term outcomes. So when I looked at all the data from more than 5 years regarding weight loss, this is a very busy slide, but I can assure you the targets of excess weight loss more than 50% in all of those studies. 10 years. So we have 5 studies that show that, again, percentage excess body weight loss is more than 50% at 10 years. And these are the 5 studies showing that. Of course, in terms of effectiveness, in terms of managing comorbidities such as diabetes, this is a paper from at the New England Journal of Medicine, randomized study, 5 years by Philip Sharrow group. You can see that if you look at the data from this red triangle, that you can see that the change in baseline at 5 years comparing sleeve to bypass, there was no difference or no significant difference. So it tells you sleeve is really good at 5 years. And to add to that, these are 2 randomized 5-year studies from Switzerland and from the Finnish group. They show there's no difference between sleeve and gastric bypass in terms of excess weight loss, in terms of remission of diabetes, dyslipidemia, hypertension. So we have randomized studies that shows at 5 years they are equal in terms of weight loss and comorbidity resolution. This is another publication from this year, 2020, by Kamal Mawaher, and you can see that this is a systematic review of meta-analysis of randomized controlled trials. He included 5 studies, and you're looking at, you can see what he showed in these 5 studies, that Roux-en-Y did a bit better in terms of weight loss, but there was no difference in terms of comparing Roux-en-Y to sleeve in terms of remission or improvement of diabetes. And you can see also Roux-en-Y did well in terms of remission, 60% of patients with reflux and 25% of sleeve gastrectomy. So sleeve gastrectomy, I'm surprised that also helped with GERD in these studies. But both had really good result in terms of weight loss. So again, randomized level 1 study showing that sleeve gastrectomy did very well at long-term outcome. And in this study as well, if you look at the dates of surgeries, it was started 2007 to 2009. That means, as all of you know as surgeons, that the sleeve gastrectomy been modified and alterated, and now I'm sure we do it much better than doing it in 2007 or 9. So I'm sure the data will be even better with all the alteration and that was done to the sleeve gastrectomy. How about comorbidity resolution more than 5 years? These are the data, and again, they did really well in terms of how sleeve affects comorbidity resolution. In terms of systematic review, these are 2 systematic review looking at comorbidity resolution, and you can see that they did really well for diabetes at long-term outcome, meaning 5 years. In one study, 60% resolution of diabetes, and the other study, again, showing the similar result. And in terms of looking at long-term outcome, again, this is another studies, systematic review, and meta-analysis again and again showing that effectiveness of sleeve on long-term outcome. How about 10 years data? So these are 5 studies that been showing in terms of, we talked about 10 years weight loss was really good, and now we're looking at 10 years for comorbidities, although this is a small number of patients, but again, we have really good resolution of morbidity. Let's compare sleeve to bypass in terms of after 10 years in terms of weight loss. Okay, so this is a weight regain 10 years after Roux-en-Y gastric bypass, published in Obesity Surgery. As you can see, 41% of patients had weight regain, especially at younger age patients. And this is an Annals of Surgery published, looking at what's the rate of 10 years of excess weight loss. You can see it's 52% at 10 years, which is same as a 5 study at 10 years after sleeve gastrectomy. The minimum one was 50%, and the others are even higher. This is from the Barcelona group, Dr. Antonio Lacey and Dr. Vidal. You can see that they compared sleeve gastrectomy to gastric bypass at 10 years, published in SWORD, and it shows that they both have similar outcomes, and they're even saying the data might support the use of sleeve as an alternative to Roux-en-Y gastric bypass in the treatment of Roux-en-Y and treatment of morbid obesity. So again, 10 years showing comparing sleeve to bypass, it shows more towards a sleeve gastrectomy. To summarize, you can see I demonstrated here randomized studies that show that weight loss is similar at 5 years, multiple randomized studies. At 10 years, I showed you data that they had similar in terms of weight loss between the gold standard gastric bypass and sleeve, similar resolution of comorbidities, and less mortality and morbidity with the sleeve. Then, of course, faster, fewer implication from nutritional micronutrition implications, simpler to be managed post-operatively, and more importantly, it's easier to be revised to other procedures if you compare it to bypass. And we showed again at 10 years the rate of resolution of diabetes with sleeve and bypass. And the other thing, if you think about sleeve and and mitigating the risk of bowel obstruction because of Roux-en-Y gastric bypass, sleeve, we don't have that risk. Again, we don't have risk of gastric ulceration, or also the excluded stomach and the risk of cancer is not there with the sleeve gastrectomy, Dumbic syndrome, complex hypoglycemia, and nistoblastosis that we face sometimes with the bypass. And also thinking about those patients who lose weight, they develop gallstone and the need of ERCP in the future, we don't have that with sleeve gastrectomy. So all these are advantages that sleeve gastrectomy have. And to summarize, to conclude, I think if we use the SWOT analysis in this kind of debate, it shows that sleeve gastrectomy has really good potential on the long term if done in the right place, the right hand, the right center. Strength, it's easier, safer, durable effectiveness. All this data I showed you. I told you a bit about the weakness and how we mitigate the weakness converting it to the surgery, adding on, and I give you the opportunities of converting it to another procedure to even have more weight loss. Could be done in a day case. And I told you the threats of the gold standard, but again, these are not threats. These are tools that we have as a surgeon to give the best care to our patient. And now we are more into personalized medicine, so we have to choose the right patient for the right procedure, and hopefully we get the right outcome. Thank you very much. And I would like to thank again Ifso for this invitation. And I really think that with this crisis, it made us feel the importance of meetings and being there with all of you. I hope everybody stays safe, and I wish we can see each other face to face very soon. Be safe. Thank you very much.
Hello and good afternoon to this interesting session, and we're going to have a big debate today. Unfortunately, I'm debating with Salman Sabbah, who's an excellent debater. We're supposed to speak about the laparoscopic sleeve gastrectomy, and my role is to prove that is not good beyond 10 years. Actually, I would have loved to present that is not good at all, 1 year, 10 years, but anyhow. So for my disclosures, I have no disclosures. And this is my case mix disclosure, and it shows clearly I am not a sleeve guy. I have very few of my cases are sleeves, and most of my work is revisional gastric bypass. To be or not to be, that is the question. And today the question is to sleeve or not to sleeve. That is the question. When you talk, you're only repeating what you already know, but if you listen, you might learn something new. In bariatric surgery, we have brand loyalty, the extent of faithfulness of customers to a particular brand expressed through the repeat purchases, irrespective of the marketing pressure generated by competing brands. And this happens to bariatric surgeons when they stick to a company, a stapler company, or a procedure like the sleeve surgeons, one anastomosis gastric bypass surgeons. Also, we have the bariatric patients. They're very loyal to their brand. They are very loyal to their surgeon. And I've seen patients with lap bands, and they had terrible results with that. And they remained very faithful to the procedure, and they like it because there is no cutting or something like when the surgeon told them this. Fanboys, it's a phenomenon in bariatric surgery. This is an arrogant person who goes into an outburst when every time something he likes is questioned. And fanboys are usually accuse others of being fanboys. Also, confirmation bias, this is common in science. The natural tendency to accept evidence that confirms what we already believe, and to accept facts that only strengthen our preferred explanation and dismiss data that challenge what we already accept as truth. And we all have the inherent and natural tendency to search for evidence that already meshes with our beliefs. It is the nature of confirmation bias itself is to dismiss all contradictory evidence as irrelevant, and so my evidence is always the rule, your evidence is always a mistake or an exception. This has happened with one anastomosis gastric bypass, and when they deny the existence of internal hernia. Ego is an inflated feeling of pride in your superiority to others, and pride and ego say I'm important because I think I should be, and of course ego is the enemy. When experts go bad, when actual experts lie, they endanger not only their own profession but also the well-being of their clients. Academic freedom is not a license to produce sloppy or internationally misleading research, and the gold standard of any scientific study is whether it can be replicated. So we used to go to conferences, hear about how good the lab band is, go home, do it, and the results were terrible. The way bariatric surgery community reports their results is completely bizarre. And actually, we don't report our results similarly, and so we're not comparing apples to apples. And you find many pieces of literature where weight loss is reported as kilograms weight loss, percentage total weight loss, percentage excess body weight loss, percentage BMI loss, and also what is the criteria for success. Is it 30% excess body weight loss, 40, 50? And also another term has surfaced, is the success criteria. When you have 50% success, that means only 50% of your patients could achieve 50% excess weight loss, which is a very poor result. And if you see the follow-up data about procedures, my own data, I have at 15 years only 40% follow-up, and I think this is very poor, although compared to the international literature, this is not bad. And let me give you an example, and we'll see this patient coming through our discussion. So if we have a 140 kilograms patient that is 160 centimeters in height, if he loses 50% excess body weight loss, that means he's 100 kilograms. 50% success means that 100 of such patients, only half of them will reach 100 kilograms. And if you have 25% total weight loss, that means this patient will be 105 kilograms. And 50% BMI loss, this patient is 102 kilograms. So either way, he's still overweight. Statisticulation and how to lie with statistics. Misinforming people by the use of statistical material might be called statistical manipulation or statisticulation. And the perfect deception in bariatric surgery is when you get an easy procedure with nice short-term success and long-term failures, who cares? And when you have a failure, you just can blame the patient for it because you have a failure rate. And what happened with the design of bariatric surgery with time, the restriction that we do initially will go away, malabsorption will decrease, hormonal changes, if any, will go away. And why bariatric procedures fail? First, obesity is not a GIT problem. We have a GIT solutions to a behavioral problem. All pouches will stretch and dilate. Small bowel will always adapt to hyperplasia and hypertrophy. Thumping will resolve. Food intolerance will improve. Appetite will return. Hormonal changes, if any, will come back, and social cultural pressures remain. And the current problems with designing a bariatric procedure is the honeymoon period, and it takes you 5 to 10 years to really know the results of what you're doing now, dilutional effect of honeymooners, and non-standard reporting and statisticulation. So with any scientific facts about procedures, we have to go through definitions, logic, true science, and fanboy science. So the definition of a sleeve gastrectomy, it is an irreversible reflux-inducing radical gastric resection that gives temporary gastric restriction. Why sleeve gastrectomy is not a good long-term procedure? Because of two things: gastroesophageal reflux and weight loss failure and weight regain. So the logic with when you do a sleeve gastrectomy is that it will dilate with time. And this is logic. Every stomach will stretch, and you can see competitive eaters when they eat tens of sandwiches and huge portions of food, and they train the stomach to dilate. And sleeve gastrectomy is actually the only self-reversing procedure in bariatric surgery, because if you give it enough time, it will dilate. And we have many variations of constructing the sleeve gastrectomy, anywhere between a bougie of 32 to 48. So a larger sleeve will dilate faster, a smaller sleeve will dilate slower, but they will all dilate. Also, the reflux-inducing mechanism of sleeve gastrectomy, it goes by logic because of the sphincter, high pressure, intrathoracic migration, and there are a plethora of studies proving that very high incidence of reflux on the long term, and we have seen results of the Barrett's esophagus that would happen in 15 to 17% of cases after 5 years. Many papers have published this already. And to try to fix this during operation and do a hiatal hernia repair is not effective to control the GERD symptoms with sleeve gastrectomy. But this fanboys would still tell you that sleeve gastrectomy does not cause reflux, and sleeve gastrectomy can be performed in the presence of reflux. A problem with the current long-term sleeve studies is that they all have small numbers, poor follow-up, or no mention for the follow-up percentage, static circulation, and variable procedure anatomy. Like this study here, it's a nice long-term study, and it states that 50% achieved 50% excess weight loss, which is a very poor outcome. But that in their conclusion, it was a good outcome. This study also that showed that 50% of the patients developed reflux. Another study, but this is a multi-procedure study, and in their conclusion that said they recommended laparoscopic sleeve gastrectomy would be done to non-compliant patients or patients that are ready to accept weight regain. This is a fact sleeve gastrectomy. Long-term results at 7 years. This study, they say the surgeons should be aware of the long-term outcome of sleeve gastrectomy, especially weight regain, and you have to tell the patients beforehand. This study here showed that 43% of the patients developed de novo reflux. Again, this is a study that is done with very good long-term outcomes on 14 of 16 patients, very low numbers. This is a confusing study where they put a lot of words into their conclusion and results. So they say success rate was 55% and excess mean weight loss is 42%, and the results are judged moderate in 31%. What is the definition of a moderate? It shows just a lot of statistication here going around. And this is 110 consecutive patients, and at the end, the follow-up here of 110 patients was only 65 patients. That is less than 60% of the patients. So as you see, a long-term sleeve, the bottom line is 50% failure, 50% reflux. The truth will piss you off, but it will set you free. Things to remember: obesity is not a GIT problem. Procedure anatomy changes with time, hormonal changes decrease with time, and results will change. The first 18 months of every bariatric procedure is the honeymoon period. Later your results at 5 to 10 years will be completely different from your initial results. Ego is the enemy of science. So in conclusion, laparoscopic sleeve gastrectomy is not good beyond 10 years. And standard technique and standard reporting are essential for bariatric surgery survival. Do not listen to fanboy surgeons who conflict with interest that attend single procedure conferences. Logic and true science should govern the bariatric procedure design. Beware of your confirmation biases and get more benefit from the bariatric science, and do not believe everything you are told. Thank you very much.
Thank you, Khalid. Thank you all for an excellent presentations. We'll take a few minutes for discussion from the break, and I will start with the first question from Professor Al Qahtani. I will refer this question to my friend Usama Taha.
Sorry, Haitham, I didn't get your question.
You were frozen.
Can you hear me, Usama?
Yeah, I'm hearing you, Haitham.
Okay, did you hear the question, or shall I repeat?
No, I didn't hear the question. You were frozen.
Okay, would you tailor,
Repeat
this is
it,
the
please.
question from Dr. Aid Al-Qahtani, would you tailor your selection of revisional procedure in patient with GERD according to the underlying cause of reflux?
You're a bit frozen, Haitham. Yet I may understood the question that I tailored my revisional procedure according to the patient symptoms. Yes, I do. Yet right now, when we go for revisional procedures after restrictive procedures, we prefer Roux-en-Y gastric bypass rather than mini gastric bypass. Yet the only lesson that we have learned from the mini gastric bypass that we lengthen the biliopancreatic limb, so we do a distal Roux-en-Y gastric bypass. It's better for the patient, better for reflux, better for quality of life. As after 3 months, 2 months and a half, 3 months, the patient, in our experience, we have a significant higher patients complaining from bile reflux after when we do one anastomosis gastric bypass as a revisional procedure. Even if they do well after sleeve gastrectomy, so we would like to play safe and go for all the revisional procedure should be long PPL Roux-en-Y gastric bypass in our practice right now, either with reflux or not.
I think we should be very careful when we talk about distal gastric bypass. So what do you understand when you do a distal gastric bypass? What is the length of your BP limb? Osama.
I do 120 meters PPL limb.
So this is not
up to 80 to 90 alimentary limbs. So the total bypassed should be not more than 200 to not go for nutritional deficiencies.
So that's more, you mimic the positive effects of the one anastomosis gastric bypass by lengthening the BP limb, but not too much. But this is, of course, not the classic distal gastric bypass. I think this is a very important message because the distal Roux-en-Y gastric bypass has a high rate of nutritional complications.
And this what has been approved by our series also. So we would like to play safe. We enhance the quality of life. And let's talk frankly, patients after restrictive procedures, they are not coming only for weight loss. They come for improving the quality of life because all the restrictive procedures affect negatively their quality of life, including the sleeve gastrectomy, if it's tight, if it's twist or kinked, or having a reflux. So the main concern here is to enhance the quality of life by let them socialize, eating well, losing some weight, even if the excess weight loss percentage after redo surgeries is not that high as a de novo procedure. So we tailor our Roux-en-Y gastric bypass according to the patient demands. As we can go for a proximal Roux-en-Y gastric bypass for patients with intractable reflux, and they are so weak and they lost weight. And when we do this, they regain some weight, they regain some nutritional elements, and we get rid of reflux. So Roux-en-Y gastric bypass, in my opinion, in spite that I have the highest series in the Middle East, North Africa, one anastomosis gastric bypass, and maybe one of the beginners of anastomosis gastric bypass in the Middle East, Roux-en-Y gastric bypass, in my humble opinion, will still the golden standard.
There was one question from the audience dealing with what do you do with the pouch when you convert from a sleeve either to a one anastomosis or Roux-en-Y gastric bypass for reflux? Do you trim the pouch to make it a little bit shorter than in the normal one anastomosis gastric bypass? How do you deal with that? That's maybe a question for Mohammed and Osama, for both of you.
So thank you for the question. Now, for the Roux-en-Y gastric bypass, we do the small pouch anyhow. So if the pouch is dilated, it depends on the pre-op assessment. If the pouch is dilated, if there is a hiatal hernia, yes, the size of the pouch has to be reduced. The hiatal hernia has to be repaired, and the size of the pouch has to be. We do the 3 to 4 centimeter pouch. So yes, it is a small pouch, and if the size of the pouch is okay and there is no hiatal hernia, then it's a different story. So it's case by case.
My answer is that we do all routine preparation for the patients after strict procedure using a multi-slice CT virtual gastroscopy, and accordingly we plan our procedures either to trim the pouch or dismantle the whole mini gastric bypass and do a new Roux-en-Y gastric bypass. And even if the sleeve is technically wrong and very large, and we may go for sleeve as long as technically was wrong. So we prepare the patient very well preoperatively by doing virtual gastroscopy, doing endoscopies, pH-metry, and everything, and accordingly we tailor our plan for the redo surgery, which is in the majority of cases will be a Roux-en-Y gastric bypass with good parameters. Good parameters means, according to the international guidelines, the pouch should be 30 to 50 cc, a 3 centimeters gastrogenostomy, and a good enterostomy, and we close the mesenteric defects.
I have a question to Salman. Salman, you see there is a lot of difference in the literature in 5, 6, 7 years outcome of sleeve varies from 30 to 70% failure with time. So do you think the reason why we have this difference is the different indication we have, or the different techniques we're doing, or the post-op follow-up? Salman, you're muted. No?
Turn your mic on.
Waiting for Salman, probably I will pose a question to Khalid.
Yeah,
Khalid, you see that the outcome of sleeve gastrectomy and Roux-en-Y gastric bypass is probably similar with slight superiority in Roux-en-Y at 5 and 7 years. Do you think that the future is for adding malabsorption or adding a restriction like the surgery you love, the banded bypass? Also, you're muted, Khalid.
Dr. Haytham, can you hear me?
Yes, now I can hear you.
Perfect. Okay. First of all, thank you for having us. And this is an important question you ask, why different patients have different outcomes. The good news is that we are learning during this process. And as you know, sleeve gastrectomy went, with a lot of studies, especially with consensus meetings. I think it's the only procedure who had a lot of consensus. We went through 5 or 6 consensus with bariatric surgeons, and there was a lot of tailoring during this period. So this technical part is one of the issues that has to do with weight loss, but also patient selection, and follow-ups. I think it's multifactorial, and if we look at the patient and management in a holistic approach, looking at all the factors, I think in the future as well, we need to think about genes and other factors that influence weight loss and comorbidity resolutions. So I think there's not one procedure that fit for everyone, but you have to look into all these factors. And again, it's Steve been here for 20 years now, and there is a lot of alteration during this period, and we learned a lot from the sleeve, and we keep learning actually. So I think it's multifactorial. Yes, I presented a few studies at 10 years, but of course we need more studies. We need more well-designed studies as well.
I do have one more question for Khaled, maybe the last one, because we must stop soon, unfortunately. Khaled, you're doing a high number of revisional surgery, and you were talking about the ideal bariatric procedure. So in your mind, what is the best current bariatric procedure, and how should the maybe ideal procedure look like? We can't hear you, you're muted. Khaled, you're muted. You have to turn on your microphone.
Hello, yeah. Can you hear me now?
Yeah.
Okay, great. So, of course, what I do is I do a banded micropouch Roux-en-Y gastric bypass. In my experience over 20 years follow-up, this is giving me a very stable weight loss without, with revisions, of course, but with not so many revisions. My follow-up rate is only 40%, which is not optimal, but this is the best I have. But regarding revising a sleeve into a standard Roux-en-Y gastric bypass, in our experience, this has been met with so many failures in weight loss. When we do transform a sleeve into Roux-en-Y gastric bypass, what happens is that patients actually gain weight. And we have seen this in the series of patients that had a severe reflux after sleeve gastrectomy, and they lost already good weight, and we tried to fix their sleeve issue only, and they come a year later asking for a revision procedure because Roux-en-Y, yes, it fixed the reflux issue, but they have gained almost all the weight that they have lost. So in our experience, adding a band to a pouch, and we actually now we do the same as Osama Taha does with Roux-en-Y. We do a 150 BP limb and 100 centimeter alimentary limb, and in our hands, this are giving very good sustained long-term.
I have one more question to Khaled, if the panelist allows, please. Khaled, what is the plan if the banded Roux-en-Y gastric bypass failed? What's your plan for a redo surgery?
What we have seen in our experience, usually the failure happens because of a development of a gastric fistula or a mechanical problem with the operation. And in these patients, when we restore them to the original anatomy, they usually resume the weight loss. So we've had a small group of patients that developed a gastric fistula, and when we fixed that, they lost the weight again. So at this part in time, we do exactly as you do. We do a CT scan to assess all the variables. And actually, we have noticed something very interesting in radiology, is that there's a significant percentage of patients with Roux-en-Y gastric bypass, they have reflux into the BP limb. And we have seen different degrees of reflux up to refluxing into the isolated stomach. And these patients actually have the mechanism that we think of the food passing forwards. It doesn't work. So the food would go back all the way to the distal stomach and then would go through the normal route. And this means that you don't have a Roux-en-Y gastric bypass. So in these patients, they benefit a lot of moving distally the anterior enterostomy into the 150 and 100 configuration.
Yet when you fix it, you don't put a band one more time.
If I had a patient that had a band erosion, when we remove the band endoscopically, they usually gain the weight. And when we do the redo surgery and add another band, they usually erode the other band. So once eroded, usually it's always eroded.
Thank you. Thank you.
Unfortunately, we really have to stop now. We are far over the time. I want to thank all of you. Haysam, thanks for co-moderating this together with me. And I want to thank all the speakers and the audience. We had more than 270 participants. Thanks all of you. Hope to see you soon in reality. Stay safe. Bye-bye.
Bye.
COVID-19 has changed a lot of things. The way we live, the way we work, the way we care for patients. One thing that hasn't changed is Ethicon's unwavering commitment to support nurses, doctors, and everyone who works for and with hospitals. We're looking towards the future and expanding virtual surgical training to educate doctors and clinical staff all over the world. We're focusing our portfolio on the tools that help surgeons and patients. Things like Plus antibacterial sutures, Dermabond Prineo, and Stratafix that help to reduce hospital stays, increase efficiency in the OR, and allow patients to recover at home. And we're accelerating new innovations, including remote wound monitoring. Every day brings challenges and opportunities. We're here, we're ready, and we're in this together.
Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
Ladies and gentlemen, please take your seat. The session is going to start. Dr. Almontasceri, you can start your introduction, please. We are ready to start. Please unmute you.
Hello? Yeah. Hi, have a good time, everybody. Thank you for Ifso Menac of Council and for Secretary for everybody for giving us a chance to be with you today and have safe time for everybody. So we reached to the last session today, which is part 3, which will be bariatric surgery for general surgeon. There will be 4 lecture and discussion, and there will be a poll at the end of the discussion. Will share me moderating, and will be the panelist of this session, Dr. Estrado Perez from Guatemala. And we have 4 speakers. Dr. Khalid Mirza will talk about sitting pathway for bariatric patient in emergency department. Dr. Mahideen Banna will talk about metabolic complications of bariatric procedure. And Dr. Abdurrahman Numeri will be talking about longer PB limb procedure, the price of higher metabolic complication for weight loss. And lastly, not the last, Dr. Tahir Yunus will talk about dumping syndrome and reactive hypoglycemia. Shortly, I will going to introduce my colleagues in this session. Dr. Estrado Perez is advanced laparoscopic surgeon and bariatric metabolic surgeon in New Life Center in Guatemala. He is the past president of Guatemalan Association Surgery and the past president of Guatemalan Society of Bariatric and Metabolic Surgery. He is the past executive director of Ifso Latin American, and he is the current president of Ifso Latin American. And our speaker, Dr. Khalid Mirza, well known. He's the current president of Ifso Menac chapter. He is the vice president of SAS-MBS and the past vice president of GOS. He is the director of bariatric surgery and obesity center in Dammam Complex Hospital. Dr. Mahideen Al-Banna from Egypt. He is a professor of GI laparoscopic bariatric surgery at Shams University, and he was well known for his publication and contribution in bariatric surgery. He is the governor of the Egyptian chapter of American College of Surgeons and the Secretary General of Egyptian Society of Metabolic and Bariatric Surgery. And Abdurrahman Numeri. Everybody knows Dr. Abdurrahman Numeri. He is the Associate and Chief Bariatric Surgeon of Carolina Medical Center, Atrium Health Director in California, in Carolina Bariatric, and he is the director of the Carolina's Bariatric Fellowship Program. Dr. Abdurrahman Numeri was the past president of Ifso Menac chapter, and he was the past president of Pan-Arab Society of Metabolic and Bariatric Surgery. Dr. Abdurrahman Numeri, well known also in communication committee in Ifso World Federation. Dr. Tahir Yunus from Pakistan. He is the consultant surgeon of advanced laparoscopic and bariatric surgery. He graduated from King Edward University in Lahore. He had the American Board of Surgery, and he had fellowship in bariatric surgery. He worked for a while in Saudi Arabia. Now he's back in Pakistan. So for sake of time, we're gonna start the session with Dr. Khalid Mirza, and after the end of the session, we'll go for discussion, and there will be a poll at the end. Dr. Estrado, you have to add anything? We can start.
Yes, hello, good afternoon, everybody. I'm Dr. Mirza presenting my lecture today, Management of Post-Bariatric Surgery Emergency. As you know, the number of bariatric procedures during the last few years is getting more and more. During 2019, it becomes 833 and 687, which is, this is coming from the Ifso global registration. It's clearly, you can see how much is the procedure increasing during last year and going more and more. And most common procedure you can see sleeve gastrectomy, Roux-en-Y gastric bypass, and also one anastomosis gastric bypass, gastric band getting less and less. But in MENA chapter and MENA area, the same thing. We have a sleeve is the more common, but one anastomosis gastric bypass, then the Roux-en-Y gastric bypass. For emergency doctors and for the general surgery doctors, you should know the modification of anatomy in this bariatric procedure because the emergency room physician must be familiarized with the complication of this procedure for any early diagnosis and treatment. If you see in the gastric sleeve, we remove almost 80% of the stomach vertically, and you will have a long sleeve of the stomach, while in the mini gastric bypass, you will have a long sleeve of the stomach, almost half of the stomach to the incisura, but the rest of the stomach will be there, the native stomach will be there, and we will have loop of duodenum, which around from 150 to 200 according to the patient BMI. You can see it is a loop connected to the pouch, which is long, small pouch. So you have to know that in the mini-gastric bypass, you will have a long, narrow tube connected to the loop of the pouch, in which the bile coming to the pouch, stomach, and continue to the rest of the pouch, while the native stomach will be there. In gastric bypass, the only difference is the smaller pouch, and we disconnect the elementary or biliary limb to distal part with the biliary limb 70 and elementary limb with up to 150 to 170. So you know how the anatomy when your patient come to you, you know that you have a pouch, smaller pouch, and one elementary limb with the 150. In the gastric band, you will have to know that you have some restrictive device in the upper part of the fundus to make you a small pouch. So this is the brief anatomy of this procedure. As you know, these patients preoperative, they are deficient. For example, you can see preoperative deficiency in vitamin A, thiamine, and vitamin D, and some other vitamins, but this is the two most important. And as you know, in our area, in MENAC chapter countries, we have the vitamin D deficiency very high. So these patients, you have to remember that the preoperative, they are deficient. In this paper, the operative management, there is a big study communicating with different emergency room, getting the response and answer for their management. So the most common thing, the patient with acute abdominal pain that occurred after 1 month or a year post-operatively may present it for assessment in management in local emergency units. So these patients can go to any emergency unit. Type of bariatric procedure, previously I said, in this study, they found that the sleeve gastrectomy, Roux-en-Y, and open Roux-en-Y, and adjustable gastric band, in which in our area, as I said, it's a little bit different. We have the sleeve, single anastomosis gastric bypass, and revisional surgery, then the adjustable gastric band. But you know, we have in the country many cases already may come to you with mini gastric bypass. Again, what is the common symptoms presented by this patient at the emergency room? The most common symptom, it is abdominal pain, vomiting, and some diarrhea. So this is, you have to know about this acute generalized abdominal pain and vomiting within 4 weeks after the surgery. These are another main symptoms they are coming to you in emergency room, but you have to be careful about vernix encephalopathy, generalized weakness, and neurological manifestation in early stage. Sign and symptoms, as I said, suspected. If you have a patient with suspected bleeding, they will come to you with tachycardia, dyspnea, vomiting, hemostasis, hypovolemic shock, melena, fever, and abdominal pain. While the other side of the patient, they come to you with abdominal pain, nausea, and vomiting, tachycardia, dyspnea, epigastric pain, left hypochondrial pain. This is a very important sign. And generalized pain, central colicky, intermittent pain, which make you thinking about internal hernia, fever, and septic shock in severe cases. So tachycardia in your patient is considered the alarming sign of bariatric surgery. In post-operative time, abdominal pain is one of the most and sometimes frustrating problem after bariatric surgery. 15 to 30% patients will visit the emergency room during the and admission during the 3 year post-gastric bypass. Management of resuscitation. This is a very important step for emergency room. All these patients, whatsoever their history of presentation or bariatric surgery history, you should start with IV fluid, oxygen, and please no nasogastric tube. We have to give thiamine 100 milligrams stat. As you know, they are deficient with the vomiting. It is more and more worse. B complex 1 ampoule, protein pump inhibitor. As you know, they make it gastritis. We have to start broad spectrum antibiotics as a primary management. Enoxaparin 40 milligrams subcutaneous if there is no bleeding. But if the patient on enoxaparin and you suspect bleeding, you have to discontinue the enoxaparin. And common laboratory tests required for admission. You have to think about all these investigation. In our institute, we add a blood type and screen, or sometimes cross-match 2 unit to be ready for blood. Amylase and lipase should be done for in all Roux-en-Y and single anastomosis gastric bypass laboratory exam were useful as a diagnostic tool. Common radiological examination required to evaluate the radiological examination, as I said, in our institute, gastrography study and CT oral with IV contrast is the most important thing. Radiological examination can give you a very good diagnosis. Like this, we can see here gastrography in simple in left side anatomy, normal anatomy. In the right side, there is a dilated esophagus, so we need to deflate the port. Again, it is all the sign of obstruction. You can see it by gastrography, and you have to deflate the gastric band so you can release this pressure. You can also diagnose the migration of gastric band. Here again, different pictures of the gastric band migration and dilatation, and also total obstruction. In emergency room, you have first step after resuscitation to deflate this tube. In gastric bypass, simply you can see on the left side, normal. In the middle, you can see the pouch and sign of leak. Simply by again a big leak and fistula. Here is a complete obstruction of gastric bypass pouch. You can be dilated, and also you can diagnose an ulcer in the 3 pictures here. Internal hernia also can be diagnosed as internal obstruction by CT scan imaging shows mushroom sign. This is a different CT scan sign. The most important, the pink sign, you can see sign of obstruction. CT scan shows also the swelling of the blood vessels indicating internal hernia, and you have to do it. This is why we said the first sign is the CT scan. Here is a sleeve. You can see in the sleeve, this is the left side is normal, even it's dilated fundus and antrum, but the sleeve tube is very nice. In the left side, this is causing severe stenosis. Again here, the stenosis, and you can see here the leak. Clearly, this is a stomach. This is a collection of the leak and the normal stomach. Again, pancreatic loop in bypass and in the mini-gastric bypass is very important. He will come to you with the severe left side fullness and pain and the hiccup and unexplained tachycardia on the left side, or the investigation will show normal. You can see simple X-ray can show you how much is dilated left remnant stomach. So the treatment here is the deflation of the stomach, even by simple needle to the abdominal, to the stomach by cutaneous. Then patient can go to the OR. Here is the date of admission. It will lead to more catastrophic complication. We have to look for the patient early transfer to ER with a better result. This is the most important other complication. Bowel obstruction, you have to think about it. Mesenteric venous thrombosis and marginal ulcer are very important. You have to know it. This is the algorithm, but you don't need to know as an emergency physician. This is an algorithm for controlling bleeding, but you cannot. It will be complete and management by ER physician. In conclusion, initial management and resuscitation emergency will be affect the outcome. Emergency doctor staff should have a knowledge about the bariatric surgery anatomy and sign and symptoms of complication. Plain X-ray and gastrography, CT scan and with oral and IV is very important. Early reference to bariatric surgery unit is must. Medical complication, we have to think about it. PE, DVT, mesenteric venous thrombosis, COVID-like symptoms in these days. Left pleural effusion indicating leak until proved otherwise. In our DMC protocol, we start as you see, IV fluid, oxygen, do not insert nasogastric, thiamine and B complex and PAPI, broad spectrum enoxaparin, as I mentioned. Our investigation, we add this X-ray and CT scan, referral to bariatric surgery team, COVID protocol, and test. We have to do it on all these patients these days, even including isolation. Thank you. This is Dr. Mirza, and I hope if you have any question, you can refer it at the end of the discussion.
My presentation today is on metabolic complications of bariatric surgery. Recent years have witnessed a widespread increase in bariatric and metabolic surgery, and according to Ifso Global Registry, 30,000 bariatric surgeries were performed in the MENA region. Bariatric surgery has proved itself as the most effective weight loss intervention and has demonstrated success in curing and/or improving metabolic syndrome and obesity-related complications. However, bariatric surgery is not without complications. The safety profile of bariatric surgery has markedly improved in recent years, that the complication rate has decreased to less than 2%. The complications can be classified into intraoperative, early, postoperative, late, and metabolic complications. Metabolic complications include dumping syndrome, hyperinsulinemic hypoglycemia, metabolic acidosis and/or alkalosis, electrolyte abnormalities including low calcium, potassium, magnesium, sodium, phosphorus, and all or one of them may cause arrhythmias and/or myopathies. Nutritional abnormalities in the form of fat-soluble vitamin deficiencies and vitamin D deficiency with secondary hyperparathyroidism. Dumping syndrome is a series of symptoms, including dizziness, nausea, and fatigue occurring after food intake. It's attributed to rapid emptying of the gastric contents into the small bowel. The etiology is multifactorial, and it develops after Roux-en-Y gastric bypass in 40 to 75% of patients, and still it can occur after sleeve gastrectomy in up to 30% of cases. Dumping syndrome may be early or late, mild or severe, and severe dumping may cause routine wasting, malnutrition because of persistent symptoms, and cytophobia, that's fear of eating. It may cause weight loss, undernutrition, or malnutrition. Early dumping is due to bowel distension, hypersecretion of GI hormones, and autonomic dysregulation. It begins within 30 minutes following meals. It causes vasomotor and systemic symptoms such as palpitations, tachycardia, fatigue, and a need to lie down following meals, flushing or pallor, hypotension, headache, and possibly syncope. It may lead to abdominal symptoms such as early satiety, epigastric fullness or pain, diarrhea, nausea, cramps, bloating, and borborygmi. While late dumping syndrome is due to a reactive hypoglycemia that occurs 1 to 3 hours after meals. Late dumping is due to hypersecretion of GI hormones such as GIP, GLP-1 that leads to hypoglycemia and vasomotor symptoms. Hypoglycemia is increasingly being recognized as a complication of gastric bypass surgeries. Relative risk increases 7-fold after gastric bypass. Additionally, asymptomatic hypoglycemia may present in 30% of bypass patients and only proved after oral glucose tolerance test. It may occur few weeks to 5 years after bypasses. The pathophysiology of hypoglycemia remains controversial. Dumping syndrome, an increase in beta cell mass, alteration beta cell function, and other factors were suggested as possible mechanisms. But the most accepted mechanism is decreased storage capacity of the stomach and the lack of rate-limiting step to food delivery into the small intestine, resulting in an exaggerated release of insulin, leading to reactive hypoglycemia. Dumping syndrome can cause an increase in insulin and C-peptide levels after meals, and the studies of other hormones found high concentrations of GLP-1, PYY, and lower levels of ghrelin and leptin. Amplification of GLP-1 levels were attributed to the anatomical alterations of the GIP, with dysfunction or hypertrophy of the beta cells, causing overstimulation and prolonged insulin and a decrease in glucagon secretion. Increase in insulin sensitivity and decreased insulin resistance may additionally contribute to the development of hypoglycemia. Some authors describe cases of non-insulinoma pancreatogenous hypoglycemia syndrome, presented with symptoms of postprandial neuroglycopenia secondary to hyperinsulinemic hypoglycemia. The diagnosis of NIPHS was confirmed pathologically by the presence of diffuse islet hypertrophy or nesidioblastosis. Cases of insulinoma have also been reported to occur after gastric bypasses, with 10% of the cases presenting with symptoms of postprandial hypoglycemia. The clinical presentation varies from asymptomatic to mild neurogenic to more severe neuroglycopenic symptoms. The neurogenic or adrenergic symptoms include tremor, tachycardia, diaphoresis, anxiety, and the sensation of hunger. And the neuroglycopenic symptoms include weakness, tiredness, or dizziness, inappropriate behavior, difficulty with concentration, confusion, and blurred vision. Most of the patients have mild adrenergic postprandial symptoms, whereas a few may have severe and refractory symptoms. Diagnosis depends on continuous glucose monitoring, oral glucose tolerance test, and imaging studies, including abdominal ultrasound, triple phase spiral CT scan, and MRI of the pancreas. The modality of treating hypoglycemia post-bariatric surgery depends on the severity of the symptoms and the response of the patient to the initial dietary recommendations. Initial dietary advice includes frequent small meals with low carbohydrate diet, and for resistant cases and for non-respondents to dietary modifications, medical treatment can be initiated with acarbose, diazoxide, verapamil, and somatostatin. Bypass reversal is the last resort. Metabolic bone disease in the form of osteopenia and osteoporosis can occur after gastric bypass surgery. However, the data are contradictory regarding the risk of impairment of bone mineral density after bariatric surgery. Some studies indicated a higher risk of osteopenia or osteoporosis, and the incidence of osteopenia is about 24% after Roux-en-Y gastric bypass versus 18% after sleeve gastrectomy, and 3% incidence of osteoporosis for both types of surgeries. Some studies show that patients are more likely to have fractures after bariatric surgery, but this risk is already present before surgery. Anyway, the data are not conclusive. Patients with osteoporosis should receive bisphosphonate after appropriate therapy with calcium and vitamin D. And for the prevention of osteoporosis, a systematic supplementation of calcium and vitamin D is required for all patients after bariatric surgery. Perioperative management involves assessment of nutritional status of the patient, rigorous clinical and biochemical follow-up after intervention and supplementation, and supplements should be given and monitored by follow-up lab results. It's recommended that patients after bariatric surgery have follow-up of blood cell count, thrombin, albumin, iron, ferric, ferritin, folic acid, vitamin B12, magnesium, zinc, phosphorus, calcium, vitamin D, parathyroid hormone, and alkaline phosphatase. And lifelong monitoring may be needed for some cases. These are my references, and thank you very much.
It's my pleasure and privilege to speak to you today about the importance of the biliopancreatic limb, a subject that is near and dear to my heart. This is my disclosure slide, and it has no bearing to this presentation. In the left lower corner, you can see the types of procedures I currently perform. The presentation today is going to be talking about the length of the Roux limb and its importance for weight loss, the length of the biliopancreatic limb. Could you have too long of a biliopancreatic limb, and can it cause malnutrition if it's too long, and what is the total alimentary limb length? I think it's important to note that procedures like Roux-en-Y gastric bypass, biliopancreatic diversion, and duodenal switch variant of biliopancreatic diversion are all forms of Roux-en-Y gastric bypass, meaning they have a Roux limb, a biliopancreatic limb, and a common channel. What makes a difference is not the fact that they have an anatomical Roux-en-Y configuration. What makes a difference is the size of the stomach, the length of the biliopancreatic limb, and the length of the total alimentary limb length, which I'll refer to in this presentation several times, which means the Roux limb and the common channel. And when someone says a patient had undergone Roux-en-Y gastric bypass, as you see in the slides in front of you, it means they had a very small pouch, about 30 milliliters. They have had a short biliopancreatic limb and a relatively short Roux limb, about 100 to 150 centimeters in length. And most likely in these patients, the common channel was not measured. The vast difference between that and BPD or BPDDS is the fact that the length is different in those procedures. Also, when you look at the main difference between Roux-en-Y gastric bypass and one anastomosis gastric bypass, you can see that the only thing they have in common is their name. One is Roux-en-Y configuration, one is loop, and the length are completely different, and the size of the pouch is also different. Similarly, when you see all different types of loop configuration of gastrointestinal surgery for weight loss or metabolic procedures, you will see that the total alimentary length represents the common channel because there's no rule limb. So is the rule limb important? Bob Brolin in 1992 published a randomized controlled trial randomizing patients to a short rule limb of 75 centimeters versus a longer rule limb of 150 centimeters and found no difference long term. Similarly, a recent study that was published in JAMA in 2016 randomized patients to undergoing the same pouch, same biliopancreatic limb, and either the rule limb being 150 or the common channel being 150. What they found was that the weight loss at 2 years was no different. And this is no surprise because in both patients, the total alimentary limb length, meaning rule limb and common channel, is the same. What they found was as you make the rule limb very long and the common channel very short, i.e. distal bypass, you could have patients with protein calorie malnutrition, and you could have patients with diarrhea and nutritional deficiencies. So I think in terms of the rule limb, the only important thing for the rule limb is to make sure there's no bile reflux. So 80 to 100 centimeters is the maximum length you need. How about the biliopancreatic limb? The first randomized trial looking at this was done in 2014, and it looked at doing a rule limb of 150 centimeters with a biliopancreatic limb of 60 centimeters versus a rule limb of 60 centimeters and a biliopancreatic limb of 200 centimeters. And you have to recognize that as you lengthen the biliopancreatic limb, you need to shorten the rule limb to make sure that the amount of bowel excluded is relatively close to each other. But they found that when you do this and you lengthen the biliopancreatic limb, you get two different procedures, one in green, one in blue. And it's different in terms of weight loss in both morbidly obese in the top or super obese in the bottom. In addition, as you lengthen the biliopancreatic limb, you get more nutritional deficiencies, namely vitamin D deficiency, hyperparathyroidism, and anemia in terms of iron deficiency anemia. So lengthening the biliopancreatic limb is not without cost. Recently, the group from the Netherlands, led by Frits Berends, has published two randomized trials, one shown here called the Elegance trial, where they randomized patients to having a biliopancreatic limb of 75 centimeters with a rule limb of 150, or a biliopancreatic limb of 150 centimeters with a rule limb of 75 centimeters. 146 patients, and what they found was the weight loss was better in the group that has a longer biliopancreatic limb. But this procedure, this trial rather, was plagued with some loss to follow-up, and that difference was lost over time. The same group did a trial in reoperative surgery called the Redo Elegance trial, or Elegance Redo, and identical setup for patients who have a band, to either have a band to bypass with a shorter biliopancreatic limb of 75 or longer 150. And here there was no loss to follow up, and the difference was maintained for the 4 years of the study. But at 2 years, there was a mean difference in favor of the longer biliopancreatic limb, as seen. But not all the studies have shown that as you lengthen the biliopancreatic limb, you will have better weight loss. This is a very nice randomized controlled trial that was published in 2019 in obesity surgery. Large number of patients, 253, larger than the trials done by the group from the Netherlands. This is from Spain. And what they found was when you randomize patients of a BP limb of 70 with a BP limb of 120 and keeping the rule limb constant at 150, there's no difference in weight loss and comorbidity resolution. But if you notice in this trial, because the rule limb is constant, the bowel excluded is different, 220 versus 370. And whether that makes a difference, we still don't know. We just know one fact. is that the small bowel length is variable. So if you lengthen the biliopancreatic limb without taking into account that the longer you make it, you need to shorten the rule limb rather, you will end up with longer exclusion of bowel. So in this trial, there was no difference when they made the biliopancreatic limb longer by 50 centimeters from 70 to 120. And that could be one of the other reasons why this is the case. In the other trials, the difference between BPLM was a little large. A recent systematic review looked at 13 articles looking at the biliopancreatic limb, and they found that weight loss was superior when you make the biliopancreatic limb longer. And this is actually one of the understandings we have. This is a systematic review in SORT from 2019. So let's consider why is the biliopancreatic limb length leads to an increase in the weight loss and comorbidity resolution. One area is bile acids. This is a small study of 26 patients that either had a sleeve Roux-en-Y gastric bypass with a BPLM between 100 to 150, or a 1 anastomosis gastric bypass with a BPLM between 200 and 250. What they found was that when they measured serum bile acids in the groups looked at weight loss and comorbidity resolution, that the 1 anastomosis gastric bypass patients had the best change in BMI, best change in insulin resistance, and best change in hemoglobin A1C. Roux-en-Y gastric bypass followed, and then sleeve gastrectomy was the least. But also the levels of systemic bile acids correlated with that weight loss, insulin resistance, and comorbidity resolution, meaning the sleeve was the least, which had no BPLM. The Roux-en-Y with the shorter BPLM was in the middle, and then 1 anastomosis with the longer BPLM was longer. Had higher rather rates of systemic bile acids. We know that distal delivery of nutrients and bile to the L cells of the ileum leads to secretion of GLP-1 and the cascade of the metabolic effects that makes all these things happen. And we know the microbiome plays a factor. But as simplistic as to think about it, the longer you make the biliopancreatic limb, you actually lead more distal delivery of bile and nutrients to the, especially bile to the L cells of the ileum. So can you make the biliopancreatic limb too long? And just like I talked about earlier, if you exclude too much bowel, you'll end up with a short total alimentary limb length, and that could have deleterious effects. The first randomized trial comparing 1 anastomosis gastric bypass and Roux-en-Y gastric bypass by Wei J. Lee showed that the weight loss at 1 year was better for 1 anastomosis gastric bypass, as seen here. And when you look at the incidence of anemia, it was higher in the group that had 1 anastomosis gastric bypass, similar to the weight loss. So again, in 1 anastomosis gastric bypass, the biliopancreatic limb is longer. And recently, the Omega trial from France, multi-center randomized controlled trial published in The Lancet, that compared the same exclusion of bowel, 200 centimeters in 1 anastomosis gastric bypass and 200 centimeters in Roux-en-Y, 50 BPLM and 150 Roux-en-Y, showed that there was higher diarrhea, styrorrhea, nutritional adverse events in 1 anastomosis gastric bypass than Roux-en-Y gastric bypass. You notice the BPLM is longer, but the amount of bowel excluded was actually the same. Bile reflux was 16% at 2 years. And this is the details of the nutritional deficiencies between the two groups, the Roux-en-Y group in the middle and the 1 anastomosis on the right. And the weight loss, as this was a non-inferiority trial, was no different between both groups. And in a study in 2016, retrospective review of all patients admitted to the ICU for nutritional reasons for a 3-year period between 2013 and 2015, 58% of patients admitted had 1 anastomosis gastric bypass. So it's often in the past used to be called mini gastric bypass, and I think that's a misnomer that simplifies the procedure and makes it appealing maybe to patients because it's a simpler procedure, yet it leads to more nutritional burst. And several other case reports have shown that the highest percentage of having nutritional deficiencies was when the BPLM was more than 200 centimeters, which is what was confirmed by the Omega trial, which I showed just previously. And some surgeons can go with biliopancreatic limbs up to 250 and 275. And again, unless you measure the total alimentary limb length, you could end up with problems if you employ this systematically. And this could lead to serious deleterious effects like protein-calorie malnutrition that could be fatal, as in this case report and other case reports. This is another one, and this is a third one. So it's important for surgeons to recognize that as you lengthen the biliopancreatic limb, you could actually end up with nutritional deficiencies. So to conclude, I'm going to talk about the total alimentary limb length, and I want to conclude by talking about these three tables. So if you look at this table, it looks complicated, but I'm going to take a few minutes to explain it. I'm going to show three tables, and the only thing I will change is the small bowel length in the top left corner. It will be 600 in the first table, and then 400 and 800. You can see the procedures: BPD, DS, SADI, one anastomosis gastric bypass, DJB, and Roux-en-Y gastric bypass. And I want you to focus on the row second to the bottom in green, the total alimentary limb length. You notice that in BPD, SADI, and DS, the total alimentary limb length is constant because this is by design. And initially, when SADI was done with 200 centimeters, this led to too many nutritional deficiencies, and many surgeons now even make this 300 centimeters to minimize the rate of nutritional deficiencies. But if you notice in this patient, one anastomosis gastric bypass is less metabolic than Roux-en-Y and less metabolic than SADI, BPD, and DS, and more metabolic than Roux-en-Y and DJB is more metabolic than one anastomosis gastric bypass. And more importantly, is not whether it's metabolic or not, but the length of bowel that can see food is variable. Because if you go make the patient 400 centimeters, you suddenly notice that, again, in SADI, DS, and BPD, it's the same length. In one anastomosis gastric bypass, it's now a more metabolic operation that could lead to more nutritional deficiencies than SADI, BPD, and DS, and DJB is even worse. You see Roux-en-Y gastric bypass have some protection of the Roux limb, but again, the total alimentary limb length is very short. And finally, if you make it 800 centimeters, and we know patients could have small bowel length longer than 800 centimeters in about 5% of patients. Again, in SADI, DS, and BPD, the total alimentary limb length is constant. In one anastomosis is now 600, and it's 750 in Roux-en-Y. So I tell surgeons before you say a patient who's regaining weight after Roux-en-Y gastric bypass with a good sized pouch and a good anastomosis that they're eating too much, you need to measure their total alimentary limb length first. So what we've learned from one anastomosis gastric bypass is there's a balance between weight loss and nutrition. I think the take-home message is that the length of the Roux limb is only necessary to prevent bile reflux, and it should be somewhere between 80 and 100 centimeters. The optimal length of the biliopancreatic limb is not known, and it is shown that the longer the biliopancreatic limb, the more weight loss and comorbidity resolution patients have, but also the more chance they can develop nutritional deficiencies, as seen in the Omega trial and what I showed you in the distalization studies and in the studies of one anastomosis gastric bypass with long biliopancreatic limb. So once someone lengthens the biliopancreatic limb more than a meter, it is important, if it's a Roux-en-Y gastric bypass patient, to shorten the Roux limb, and if it's a loop patient, to actually measure the entire small bowel length to determine what is the total alimentary limb length. In general, if you distalize a Roux-en-Y gastric bypass, you should perform a type 1 distalization, and you need to make sure that the total alimentary limb length is between 400 and 450 centimeters, and it is not acceptable to have a common channel similar to BPD and DS of 100 or 150 in a patient with Roux-en-Y gastric bypass because they have a very small pouch. Again, thank you very much for the opportunity to present today.
Hello, everybody, and thank you very much for this opportunity to present dumping syndrome and reactive hypoglycemia at the Ifso Menac Virtual Congress. My name is Dr. Tahir Yunus. I'm a consultant bariatric surgeon. A little bit about myself. I did my postgraduate training with Dr. Kelvin Higa in Fresno, California. I moved to Jeddah, Saudi Arabia, became part of the Ifso Menac group in Saudi Arabia, and now recently I've just moved to Lahore, Pakistan, where I've established my private practice. As disclosures, I'm a speaker for various bariatric surgery meetings sponsored by both J&J and Medtronic. This is my case mixed disclosure. So regarding the talk today, we'll be focusing on the introduction to dumping syndrome, looking at its clinical manifestations, the diagnostic challenges, non-surgical therapies, and surgical options that are available. So as an introduction, the term was first coined in 1913 by Dr. Hertz, and it gained its traction in 1970s with the six-stat scoring system. It involves a constellation of symptoms that are involving both GI symptoms and autonomic nervous system. Primarily, these symptoms occur after esophageal, gastric, and bariatric surgery, and including gastric fundoplication. The two types of symptoms, we have the early dumping syndrome, which occurs within 1 hour, and it's primarily the gastrointestinal system symptoms and vasomotor symptoms that are following a meal. But it could also be later than an hour, which is called the late dumping syndrome, which leads to reactive hypoglycemia postprandially. And this actually causes the neuroglycopenic symptoms, especially after a carbohydrate meal. What's interesting is that the late dumping syndrome doesn't occur within the first year after surgery and actually has a late onset. So early dumping occurs within an hour of eating the meal, and it's primarily driven by hyperosmolar food shifts that lead to fluids going into the intestines and causing small bowel distensions. It's mediated through a variety of different gastrointestinal hormones and vasoactive peptides. It can occur with both sleeve gastrectomy as well as with a gastric bypass. Patients typically complain of pain, symptoms, bloating, nausea, could have diarrhea. The vasomotor symptoms lead to palpitations, flushing, a desire to lie down with fatigue and hypertension. It's important to differentiate these symptoms from other possibilities such as stricture stenosis, gallbladder stones, and internal hernia. And as it can be seen, it does lead to a very low quality of life scores. A late dumping syndrome is different from the early dumping syndrome because it occurs an hour after the meal. And it actually, the absorption of the carbohydrates causes a rapid rise in the blood glucose levels, which drives incretins that cause a hyperinsulinemic response, leading to hypoglycemia. The hypoglycemia stimulates sympathetic nervous system that causes palpitations, tremors, sweating, and even aggression. And the neuroglycopenic symptoms as a result of the hypoglycemia include fatigue, weakness, confusion, and even syncopal episodes. These symptoms can actually lead to motor vehicle accidents, falls, and injuries at work, which makes it quite concerning. And contrary to what we originally thought, that these symptoms would help with weight loss as patients would avoid sweets, they actually lead to weight gain because they end up having frequent small meals to correct the hypoglycemia. The challenges that we face in diagnosing this condition is that most of these symptoms are reported by the patient. And so when you develop questionnaires to document the symptoms, these questionnaires are not always very accurate for the different conditions that they're going through, such as the six-stat dumping scoring system was actually developed for peptic ulcer disease gastric surgery. And so there are flaws within the scoring system and cannot be applied to the bariatric population. Furthermore, most of these scoring systems have not been validated, and they lack a consensus on definitions. With regards to provocative testing, we have the oral glycemic tolerance test, oral glucose tolerance test. And the oral glucose tolerance test involves a 75-gram carbohydrate or glucose load that the patient takes as a liquid form. However, this may lead to an early dumping syndrome, and actually it doesn't correlate with the patient's symptoms as well. The mixed meal test is more accurate. It includes a combination of proteins, fats, and carbohydrates. Unfortunately, the mixed meal test itself is also has not been defined, and so there's no consensus on what it should include. However, when a mixed meal test is conducted and the patient has within an hour symptoms that include an elevation of their pulse and an elevation of their hematocrit, it does suggest an early dumping syndrome. And if they develop hypoglycemia after an hour, it does suggest a late dumping syndrome. The continuous glucose monitoring is a better tool for understanding complex cases and for diagnosing these cases. The next slide will actually show how these tests can be then used for diagnosing these conditions. And so you have the solid dark curve that is the hypoglycemic patient after a gastric bypass. And you have the gray curve, which is a non-surgical control. And then you have the dotted curve, which is an asymptomatic gastric bypass patient. So you can see that all of them have a similar fasting glucose level, but after the mixed meal provocative test, the insulinemic response, the glucose response in the hypoglycemic patients shows a rapid rise and rapid drop as a result of the incretin-driven hyperinsulinemic response. The issue is, however, we lack a consensus on the definitions of hypoglycemia that occur after the rapid rise. And so that what makes it difficult to actually identify the true prevalence of the disease. However, it is assumed that less than 1% of gastric bypass patients have severe hypoglycemia that will actually require hospitalization, and less than 10% will actually have clinically recognized hypoglycemia. So what it is recommended is that we should have a multidisciplinary team that addresses these patients to properly identify them and diagnose their condition. The ASMBS position on this condition is that the incidence is low, and they've quoted a number of studies that show this low incidence. But again, the challenges that we face with the diagnosis is that we lack a consensus between these different studies. However, the ASMBS position does state that most of these do resolve with proper dietary counseling and modifications. They've established 4 points as a criteria for diagnosing it, that the symptoms occur after a year. They include normal fasting and insulin levels. They correlate a correlation of the symptoms with hypoglycemia followed by spontaneous resolution of hypoglycemia, and a positive provocative test, including the mixed meal test. Treatment for this condition primarily lays on lifestyle changes and should be adopted for at least 3 to 4 weeks with a food journal tracking. Patients should be counseled to have meals that include mostly proteins and some fats, and limit their carbohydrates and keep their carbohydrates in the low glycemic index and avoid high glycemic index carbohydrates. Recommend that the patients take high fiber within their diet that would prevent or blunt the rapid absorption of the blood sugars. Having small frequent meals instead of larger meals would prevent the hyperosmolar fluid shift. So it requires a lot of education and counseling, and especially to explain to the patients what they should be avoiding, different foods that would worsen their condition. Adding different food supplements or additives that would increase the viscosity has been shown to blunt the early dumping syndrome as well as the late dumping syndrome. After lifestyle modifications, pharmacological interventions can be adopted, which include first-line therapy using acarbose, which is an alpha-glycosidase hydrolase inhibitor, and so it reduces the amount of carbohydrate digestion and blunts the hyperglycemic response and subsequent hypoglycemia. It has been shown to improve or reduce the GLP-1 production and better profile for continuous glucose monitoring. The dose recommended is to start at 50 milligrams 3 times a day before or with meals and gradually titrate it up to 100 milligrams 3 times a day. And you can add pectin 4.2 grams after the meals as well. If patients fail with a glucose due to the side effects or intolerance to the medication, the second line would include somatostatin analogs, which are octreotide and pasireotide. These are short-acting as well as long-acting. The short-acting one is a subcutaneous injection that's given 3 times a day. Once the patient gets started on that for 2 weeks, then it can be shifted on to the long-acting one. However, one note over caution over here is that it does induce gallstones, and so that has to be taken care of. Other drugs that have had case reports include nifedrin and diazoxide. Surgical treatment, there has been well proven that there is no role for a distal pancreatectomy. G-tube feeding through the remnant stomach has been effective in restoring the glucose homeostasis and reversing the hormonal abnormalities. And it does help establish whether restoring the anatomy of the GI tract will reverse this syndrome. And so reversal of gastric bypass has been proposed for severe cases, but it is associated with significant morbidity. Some case reports have shown conversion to sleeve gastrectomy has been helpful and without a short-term weight regain, but it does cause increased GERD. Thank you very much for this opportunity to give this talk, and I'll be glad to take questions after this in the discussion.
Thank you for our great speakers. It's a really excellent lectures, highly informative. Thank you very much. Now we'll have plenty of time. We are lucky we'll be the last session. So we have first Dr. Stradu, parents, will take discussion with all speakers. Then we'll have, I will take the question from the audience. And the last thing, there will be one question poll. Also will be subject to all discussion with the speakers and Dr. Stradu. Go ahead, Dr. Stradu.
Thank you very much, Dr. Amontasheri, and thank you, my dear Khalid Mirza, for the invitation to be here with you, all my friends here. Latin America is here with you, Menac. Thank you very much. Khalid, you did a great presentation. This symposium is bariatrics for general surgeons. And this is a real problem because sometimes in the emergency rooms, there are no bariatric surgeons. There are only emergency surgeons. So you show us beautifully and well described what they have to do. I want that general surgeons are hearing us. The most important thing is to identify if this complication is late or early after the surgery. So the follow-up of the procedures must be of utmost importance. If the early complications of these things, you can see bleedings, you can see patients almost dying. So the most important thing, the most vital sign, which vital sign do you think, Khalid, is the most important for the surgeons in the ER to see in these patients with early complications? You're mute.
Okay, now it's okay. I think during last 2 years, I work in university hospital, and it is a very busy hospital receiving all the complications from the area because it's all the government receiving. So I tell all the patients, all the doctors, when the patient comes, take proper history, look for tachycardia and dyspnea. Dyspnea, fever is not an ELE, but if the patient comes dyspnea and shortness of breath, this is a very important sign. Abdominal pain, all of them, abdominal pain can be simple gastritis. They come with abdominal pain. Can be distension, abdominal pain. But you have to think about, this is a very serious issue. You have to investigate and take the patient to the CT scan with oral and IV CT scan. So they can, we have seen many patients, they send them back from ER to their home and they have a leak.
organizing
Yes.
committee of the EPAS conference.
So this is, I think, the most important sign for these patients in the ER. For the ER.
Okay, great. Yes, of course. The tachycardia is the best one. Okay. And the suspicion, the patient feels that he's dying, he feels death. So the suspicion must be very important. Very good. Dr. Alvana, very nice presentation too. Complications of bariatric metabolic. Metabolic things are very important. Which one of those do you think is the worst of those metabolic complications we can see in the patients? For the bariatric surgeons and for the general surgeons in the ER, what do you think about that, Mohi?
I think it's hypoglycemia, reactive hypoglycemia that we experience after gastric bypass. And usually the presentation is late, probably years after the procedure. So it needs a high index of suspicion to diagnose it. And some of the patients, they don't come to the bariatric surgeon. They go to physicians. And sometimes they don't even mention that they had a gastric bypass. So it's very important to tell the patients about it. The patients need to be aware that they may have this complication, and when they get this complication, they need to come back to their surgeon. And of course, management of such cases is a little bit tricky, and it needs a multidisciplinary team. Because we need the endocrinologist with us to treat this patient. And I think in the MENA region, we are in bad need for bariatric physicians because some of the patients, they need special care after the operation when they develop such kind of complications.
And what about osteoporosis? Oh, sorry, Khalid. Yes.
I think for in our area, because of increasing malabsorptive procedure, the most important metabolic complication, which can kill the patient, is protein malnutrition and severe lower limb edema. These patients come late and they may die with liver failure. And the other important complication, and we missed it in the ER, the Wernicke encephalopathy, which management is very easy, but the patient can go to medical ward, biopsy, intubation, and he has only severe thiamine deficiency. So these two very, very important issues. Others important but can be managed and will not kill the patient. Patient die from Wernicke's encephalopathy and severe thiamine deficiency, and also we lose the patient because of liver failure. They come and send him back if they have severe protein malnutrition. This is also, I think, one important metabolic complication.
And what about the osteoporosis, Mohi? How often do you see that?
Well, usually yes, it's a bit common because we have many patients who have vitamin D deficiency. Some of our patients already have joint problems. Maybe this is the indication for surgery in many of our patients now. So they already come with osteoporosis before the operation. This needs diagnosis, preoperative diagnosis, because they will need special post-operative care. And maybe we would be reluctant to offer such patients a malabsorptive procedure or even one anastomosis gastric bypass, which is more common in the region than Roux-en-Y gastric bypass, because probably the incidence of osteoporosis after one anastomosis gastric bypass is more than after Roux-en-Y gastric bypass.
Okay, great. My dear friend Mary, okay, you're a teacher. You show us what about the importance of the biliopancreatic limb and the tall. Do you think that there exists the ideal gastric bypass? It's a nice question.
Oh. Okay, that's better. Okay. Thank you, Dr. Behrens, for a very important question. I think we as surgeons need to shy away from using the words gastric bypass without knowing the limb length, the size of the pouch. So I'll give you like a quick example. I see many patients in my clinic who have got either weight regain or marginal ulcer after Roux-en-Y gastric bypass. But when I do an upper GI study or I do an endoscopy, they have a very large pouch. So their weight regain and their marginal ulcer could be explained by their anatomy. We have to recognize the longer you make the pouch, the larger you make the pouch, it doesn't only affect weight loss, but it causes a higher incidence of marginal ulcer. So when we say Roux-en-Y gastric bypass, we mean a pouch that was made with 3 cartridges of 45 to 60. We mean a very short biliopancreatic limb that's 50 centimeters or less, and a rule limb of around 100 to 150 at the most. Anything out of that configuration, this is a different procedure and it will have different results. The longer you make the BP limb, the larger you make the pouch, just because the patient is bigger or anything else. So I do agree with you. The word Roux-en-Y gastric bypass gets thrown a lot, especially in the US, because it's been done since the 60s. When you look at the patients, not everybody has the configuration of what Roux-en-Y gastric bypass is. I hope I answered your question.
Oh, yes, yes. But what do you think if you do a Roux-en-Y gastric bypass with a biliopancreatic limb, 1 meter, and 1 meter of the alimentary limb? What do you think about that?
Yes, absolutely. We do this for all patients who have a BMI less than 50. And based on the Elegance and Redo Elegance trial, if the BMI is over 50, we lengthen the BP limb to even 150 and shorten the Roux limb to 75 centimeters. But in both cases, you need to make sure that the pouch cartridge length is less than 3 cartridges. So this was shown by the Swedes in the Swedish registry very well, where the surgeon is asked how many cartridges it took to perform your pouch. And their mean length is 145 millimeters, which means 145 and less than 260s. And they showed that every increase by 10 millimeters increases the marginal ulcer rate by 14%. So many of the complications of Roux-en-Y gastric bypass are because of the technique. So internal hernias because you didn't close the defects. Many of the marginal ulcers because you operated on a smoker or you made it a large pouch. Many of the weight regain is because of the construction. So I'm not saying these things don't happen, but the rates should be exceedingly low.
So you, in talking about the one anastomotic gastric bypass, how often do you perform that MGB or AGB? Or you don't perform?
Sure. I performed it once in a patient who insisted that they have it. I found it technically easy. I am concerned to perform a procedure that over a long time, we're going to find out there's issues with viral reflux. I'm still from the people who think that if I make the pouch too long, I'm going to have a higher rate of marginal ulcer. And now there are, like, look at the study from the group of Malphobi in India, showing that their marginal ulcer rate is high, double digits, and it's mostly in asymptomatic patients who present with perforation for the first time. So I'm concerned that as I make that pouch larger, I'm going to end up with problems with marginal ulcer. And what makes the risk of marginal ulcer low in Roux-en-Y gastric bypass is that small pouch. And in the one patient I did, I measured the entire bowel, so I knew exactly what the common channel was, what the BP limb was.
So, Dr. Barnes, can you go to Dr. Your question, direct question, Dr. Tahir, because we are short of time. I will split our questions from that.
Thank you, Tahir. Wonderful talk you gave us. That is a nightmare. It is a nightmare. That dumping syndrome is a nightmare. Which one of those do you see often? The early or the later dumping syndrome? Which one is more frequent?
Well, the early is much more frequent than the late, and it's usually related to the type of food that they're eating. But I have seen in the last 10 years about 2 or 3 patients who had severe neuro. Can you hear me?
Yes, I do.
Hello?
Thank you. Yes.
Okay. So I'm going to repeat myself. I said that the early dumping syndrome is more frequent than the late dumping syndrome, at least in my observation. but I have had about 2 or 3 patients with severe neuroglycopenic symptoms, late dumping syndrome, and a couple of them I have had to reverse as a result of those symptoms. And the problem is that it could be, it could really handicap a patient because they're always carrying these glucose tablets with them, and they're always worried that they're going to have, the symptoms come up when they're driving or they're doing something important. So the late dumping syndrome is very less frequent, but does happen. And it requires a lot of multidisciplinary management, especially with regards to changing their eating habits and addressing the different reasons why it's happening, and making sure that there are no other confounding reasons such as an insulinoma or something else.
What did you offer to those patients that you reversed the gastric bypass? Did you try to make a sleeve on those patients, or just reverse the gastric bypass? They regain weight?
So I just reversed their gastric bypass and they did regain some weight, yes.
Okay, so it's really a nightmare. I only had one of those cases and I reversed that too. I didn't try to do the sleeve.
And the reversal is not a very simple procedure because they do tend to have complications, especially bleeding complications with the anastomosis that when you redo the gastrogastric anastomosis, there is a tendency to have bleeding from the staple line or the anastomotic line.
Thank you very much. Ali, do you have any questions from the audience?
Yeah, yes, of course, yeah. So we'll go quickly. We need quick answer, dear speakers, okay? So the first question from Prof. Niami, Ashraf Haddad and Osama Taha, almost the same word, and Mary Abdurrahman. Would the restriction of the gastric, Dr. Prof. Niami is asking you, would restriction of the gastric pouch will cause additional difference in weight loss and metabolic consequences? And the question from Dr. Osama Taha, he's asking you, what should the BB limb length in your practice? Dr. Ashraf Haddad is asking you how you choose the BB limb in revisional surgery after sleeve gastrectomy. So if you can answer it in less than 1 minute.
Sure. So we don't do restriction of the pouch or revision of the anastomosis because the literature shows that it doesn't help unless someone has a huge retained fundus. I usually do a BP limb of 50 centimeters if the BMI is less than 45, 100 if it's between 45 and 50, and 150 with a rule limb of 75 if it's more than 50. And I try my best not to offer patients with BMI over 55 Roux-en-Y gastric bypass. I offer them duodenal switch or SADI. And in reoperative surgery after sleeve, what I've had very good results with is I explore the hiatus on almost everyone, and many times I find that they have retained stomach on the left side. I refashion a small pouch, and if their BMI is less than 50, I use 100 centimeter BP limb. If it's more than 50, 150. And again, if someone had a sleeve and their BMI is over 50, I tell them their best operation is a duodenal switch unless they have severe reflux.
Okay, the next question for Dr. Khalid. This is from Dr. Ahmed Bashir. He's asking you, what's your message for a patient coming from areas with no bariatric surgeon at the area, and you operate on them? How are you gonna deal with them? They're coming like from areas there is no available bariatric surgeon, and they receive bariatric procedure with you, Khalid.
Yes, we consider a complication of post-bariatric surgery as an emergency, and most of the management in the hand of a capability of bariatric consultant general surgery. Bleeding can be controlled, but it is not the management as much as the diagnosis. They should know what is the diagnosis. That if you have a bleeding, internal or external, it is a general surgery issue. If it is a peritonitis, we will not talk about detail. Peritonitis causes perforation. They do the basic principle of surgery. It is early intervention, washing of the abdominal cavity, put a drain, and try to communicate. So it is mainly not the management, which is not difficult for general surgery. It is the recognition of the complication and intervention early. As we delay, the mortality morbidity become high. So early intervention and apply the principle of surgery until you transfer him to further management to bariatric center.
Okay, for Dr. Tahir, there's a question that any intention to reverse the Roux-en-Y gastric bypass and dumping syndrome and when to use it. This is question came from Dr. Haider Sharafa.
So the first line of management should always be to address the patient's eating habits and journal tracking of their food, because there will be areas of improvement that we can accomplish. So it should be in combination with a nutritionist and an endocrinologist. After that, then we should try pharmacological therapy with acarbose as well as the octreotide. When all of these fail, then one can insert a G-tube into the gastric remnant and see if feeding the G-tube reverses the symptoms. If it does reverse the symptoms, it is an indication that reversal of the gastric bypass would help the patient. And at that time, a serious discussion has to be taken with the family about the pros and cons of surgery and the possibility of converting it to a sleeve gastrectomy or just to reverse the gastric bypass. When inserting the gastric tube, inserting it at a location that it will not affect the subsequent surgery is important. That should be kept in mind when inserting the G-tube.
Thank you, Dr. Tan. So now I think we have to stop for the question for now. We need to see the ball from our kind organizers. Then I'll take the answer from the speaker and we'll find the final percentage. Okay. So this is just it's shortened because of the space. So I'll just elaborate more. This is 55-year-old female lady. She's known diabetes for almost more than 20 years. She's on insulin, poorly controlled, significant joint disorder, and osteoporosis T-score less than -2.5. She came seeking bariatric operation. So what the best bariatric operation you think is suitable for this patient? Restrictive laparoscopic sleeve gastrectomy, long limb bypass, one anastomosis gastric bypass, SADI, or you will not offer any bariatric operation. Till we have the answer from the attendee, I need our valuable speakers. Dr. Mihri Banna. Dr. Let's start with Dr. Parents. What do you think, Dr. Parents? What's the choice you will choose in this patient?
May I ask about the BMI of the patient?
Let's say it's candidate for bariatric surgery, 45.
Okay, I think I will offer this patient a sleeve gastrectomy. She has osteoporosis and her diabetes has passed 10 years. So there are studies that show that both sleeve gastrectomy and Roux-en-Y gastric bypass would give the patient the same results, the same outcome when it comes to resolution of diabetes. So I would offer her a sleeve gastrectomy. I would be very reluctant to give this patient OHAB or SADI procedure.
Dr. Muhyiddin? Dr. Banna?
Yeah, that was me. Yeah, that was me. Hello? Do you hear me?
Yes, we hear you.
Yeah, we heard you.
Hello, Dr. Banna?
Yes.
Yeah, so I think Muhi already answered. I can tell you my opinion. I would do a long limb Roux-en-Y gastric bypass.
With osteoporosis? The risk is it is more than in standard Roux-en-Y bypass, the risk of severe osteoporosis is almost 34% in standard Roux-en-Y bypass compared to 16% in the sleeve gastrectomy, post-sleeve gastrectomy.
I mean, I will discuss with the patient both the options of, I mean, obviously this patient, I will tell her she should not have SADI or one anastomosis. And then I'll discuss with her the results of Roux-en-Y and sleeve for diabetes. We'll go through the calculator and we'll look at her osteoporosis and then we'll make a decision. So between the Roux-en-Y and the sleeve, but she will not get SADI or one anastomosis because of the osteoporosis.
Khalid?
Osteoporosis can be treated and pre-operative. We cannot take the patient because of osteoporosis or diabetes or of vitamin deficiency. So we have to optimize the patient, whatever procedure you select. So we cannot say osteoporosis, and I will take it to her. This should be corrected pre-operative, whatever pathology. Then we decide which operation he needs. So if it's corrected,
this is common. This is common scenario. Patient blood density is very low. Patient is old age.
Medicine, not like this. I will correct
treatment. Patient on treatment.
Many gastric
Patient
bypass.
already on treatment, but
so it is failed. It's over treatment. It's failed. I correct her, optimize her condition, and go for gastric bypass.
Dr. Tahir?
Yeah, well, I have a few comments here. So if somebody's been on insulin for 20 years, and we're assuming it's type 2 diabetes that has reached the extent of needing insulin, so it means that there's been an extensive deposition of fat, pancreatic fat. And whenever there's pancreatic fat, visceral fat comes along into the liver as well. So the likelihood of having extensive fatty liver disease that could be even cirrhosis is a strong possibility. In which case, both long limb gastric bypass and mini gastric bypass should be avoided. And we will not actually offer any additional benefit for controlling diabetes with those procedures, and a sleeve gastrectomy would offer the weight loss and the control of diabetes that could be offered similarly with those procedures. So that's my opinion.
Okay, so the result of the poll, almost 43% will go with laparoscopic sleeve gastrectomy, 26 one anastomosis gastric bypass, 70% with long limb, and 5% for SADI. Dr. Behrens, you have to add anything before the end?
No, thank you very much. I do agree with Tahir. I do the sleeve gastrectomy too. 20 years of insulin dependence is not easy. It's not easy. No, because this is a symposium for general surgeons, the message must be that if you don't understand what are you looking at the emergency room, please ask the patient, who is your surgeon? Give me his phone number. Or who is your specialist? Who is the person who's taking care of you? Because sometimes we can see that in Latin America often, people, they don't understand what is a gastric bypass. So they think, oh, it's just gastritis, just put an endoscopy, and it was not a problem. So please, guys, ask the patient what procedure he has or she. She says, I have a sleeve gastrectomy, I have a gastric bypass. Okay, please tell me the name of your surgeon. And please call the surgeon, ask him. That will be better than try to go in. Sometimes
okay.
With the bands, same with the bands. Thank you.
Okay, so we have to stop because the satellite session is waiting for us. Thank you for all the speakers. Thank you, Dr. Behrens, for co-chairing the session with me. It's a great pleasure to be with you in Ifso Menac. See you soon in reality. Thank you.
Thank you very much. Thank you, Khalid. Thank you, everyone.
Thank you.
COVID-19 has changed a lot of things. The way we live, the way we work, the way we care for patients. One thing that hasn't changed is Ethicon's unwavering commitment to support nurses, doctors, and everyone who works for and with hospitals. We're looking towards the future and expanding virtual surgical training to educate doctors and clinical staff all over the world. We're focusing our portfolio on the tools that help surgeons and patients. Things like Plus antibacterial sutures, Dermabond Prineo, and Stratafix that help to reduce hospital stays, increase efficiency in the OR, and allow patients to recover at home. And we're accelerating new innovations, including remote wound monitoring. Every day brings challenges and opportunities. We're here, we're ready, and we're in this together.
Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way, by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
Ladies and gentlemen, next session is going to start.
So good evening, everyone, and welcome to the Ethicon Symposium on Empowering Research in the MENA region. My name is Faisal Abdelmajid, and I'm responsible for obesity marketing in the Middle East. At Johnson & Johnson, we believe our first responsibility is to the patients, to doctors, nurses, to mothers and fathers, and all others who use our products and services. In meeting their needs, everything should be of a high quality. In this context, we are proud to collaborate with the Research and Scientific Committee at Ifso MENAC to further encourage research initiatives in the region, and we will hear more about it from our eminent speakers today. We are proud to have with us today Professor Bassem Safadi joining us from Beirut, Lebanon. Professor Safadi is chairing the Department of Surgery at the Lebanese American University Rizq Hospital, and he is the president of the Lebanese chapter. Professor Safadi will take us through why research is needed in the MENA region. Also, we are proud to have Professor Carl Miller joining us from UAE. Professor Miller is Chief Medical Officer at Johnson & Johnson, in addition to his actual practice in surgery, and he presided several national and international societies, and he's very much active in training and education. Professor Miller will take us today through in the second talk, through what are the considerations to conduct a strong research that can lead to reliable conclusions. We will have time for discussions, to address any questions from the chat box, and to look at how we can practically start encouraging research. So without any further ado, I hand over the word to Professor Safadi to take us through his first talk. Thank you.
So hello, this is Bassem Safadi. Thank you, Dr. Carl Miller, for the invitation, Mr. Faisal Abdelmajid for the invitation, and Johnson & Johnson for this session. My talk is going to be on how to empower research in the MENA region. As part of my disclosure, this is my mix of cases. I do mostly sleeve gastrectomy. I do some Roux-en-Y gastric bypass and single anastomosis gastric bypass and revisional surgery. So this is the Ifso MENA region. We have a new addition of Pakistan, and we are still working on getting some of our colleagues from Morocco, Algeria, Tunisia on board. If you look at the map of obesity worldwide, you can see that the Ifso MENA countries are one of the highest prevalence of obesity worldwide for both men and women. We account for about 5% of the world population. Despite that, we have the highest rates of obesity and metabolic syndrome worldwide. And this is troubling, particularly in light of having a very young population. And this has significant implications on our health, well-being, as well as economic productivity and cost in general. Obesity is multifactorial. There are genetic factors, behavioral factors, as well as environmental factors. And we are probably unique in that sense. And we have to address all of these to better understand why obesity rates are so high. There's certainly a big component of a behavioral problem, and it might be influenced by the weather because of the high degrees of temperature, which might indirectly lead to a sedentary lifestyle. So knowledge is power, and without knowledge, societies cannot move forward. We cannot understand the causes and risk factors of diseases such as obesity. Without numbers and data, we cannot drive policy changes, and we are unable to monitor results of our interventions. And that's why research is coined with the term development. Research leads to development. So when you look at the number of bariatric surgeries done, the MENA region is one of the highest concentrations of bariatric surgery worldwide. Yet, despite that, we do not have a robust research program. And as highlighted here by Dr. Salman Al-Sabah, there should be a plea for more research in the MENA region. And since the year 2014, we have noticed a progressive increase in the number of publications in this region. So what do we need to have a robust research environment in the MENA region? One, it has to start with the culture of critical thinking, of scientific endeavor, and we have to have an infrastructure. We need human capital, and also we need physical infrastructures, and as well as medical schools, medical centers, and research centers. We need resources to fund research activity. We need to have also a clear policy and direction, and we have to have stability, political stability, financial stability, which unfortunately is lacking in many of the MENA region countries. We have noticed over the past few years an increase in the number of publications coming from the MENA region, and not only number, but also very high quality. This is a sample of the work Dr. Aif Qahtani has done in Saudi Arabia, in which many of these papers have become seminal papers, reference papers, for example, in the surgical treatment of obesity in children, and the surgical revisions of sleeve gastrectomy, and in endoscopic sleeve gastroplasty. We also have noticed a rise in randomized prospective clinical trials. These are few of the papers I quoted, and most of these come from Egypt. These are both surgical and anesthesia related. So what are current priorities in terms of research? And these are my personal opinions. I think at this stage, we really have to establish the safety of metabolic and bariatric surgery in the MENA region, establish the efficacy, at least in the mid and long term. We have to compare different procedures, particularly since many of the new procedures are originating from the Middle East, but they are not well studied. It's very important to compare different patient populations, different perioperative interventions such as diet and exercise and pharmacotherapy. We have to incorporate patient-related outcomes because we really need to understand the patient's perspective after bariatric surgery. And we have to understand also and balance the results long-term as far as weight loss and resolution of comorbidities with complications and side effects. So how do we do that? Obviously, randomized prospective clinical trials are the premier level 1 evidence. However, randomized trials can only address limited questions. They're very expensive, with budgets running in the hundreds of thousands and millions of dollars. They have to have a sophisticated infrastructure with a lot of human personnel and medical facilities, and they may not answer questions, and they take quite a bit of time to conduct. Registries and databases can provide us with answers to many of these questions that we want. It can help us study outcomes and patterns of care, compare risk-adjusted outcomes, identify areas of improvement, understand causes of complications and poor results, improve safety and quality of care, examine long-term outcomes, look at specific patient population diseases or complications in more detail, and will give us a more realistic reflection on the practice as compared to randomized controlled clinical trials. The use of registries is pretty old. This is a picture of the Metropolitan Life Insurance Company, where in the 1940s, one of their biostatisticians started examining the impact of increased weight or BMI on mortality. And this is the concept of ideal body weight or desired body weight came from that examination. Further registries conducted by clinicians confirmed the link between obesity and premature death. And registries are very important in understanding surgical care. And I chose to highlight the example of the NSQIP and tell you a little bit more of its history and coin that to what is happening currently with bariatric surgical registries. So the NSQIP started in the mid to late 1980s. The Department of Veterans Affairs in the United States came under a great deal of public scrutiny over the quality of surgical care in its 133 VA hospitals. At that time, the perception in Congress was that the operative mortality at VA hospitals were significantly above that of the private sector, which was considered at that time to be the norm. To address the gap, Congress passed Public Law 99-166 to address the gap, which mandated the VA to report its surgical outcomes annually on a risk-adjusted basis in reference to patient severity of illness, and then compare them to national averages. And that picture on the right is the late Professor Shukri Khoury, who I'm proud to say is an AB graduate, and he is the one who founded NSQIP. The only problem at that time was that there were no national averages, and these did not exist. And that's what prompted Dr. Khoury at the VA hospitals to establish NSQIP. The NSQIP started first examining the outcome of cardiac surgery, and that led to a significant reduction in surgical mortality and morbidity. And with that successful example, the NSQIP was expanded further to cover almost all surgical disciplines. And again, with that successful story, it moved from VA hospitals to private hospitals, and now it's applied to hundreds of medical centers around the United States. This is a graph showing the observed over expected complications across many hospitals, and you can see here that the outliers, low outliers with excellent outcomes where the observed outcome is better than the expected, and on the other side is are hospitals where they need improvement. So hospitals can get these reports annually from the NSQIP. They can identify areas of weakness that need improvement. I'll give you examples here. You can look at overall mortality, overall complications, cardiac complications, among others. And this is an example where you can adjust your outcomes. So going from an outlier where the observed over expected mortality is high to more in line with average, and that requires specific interventions. I used the NSQIP registry examining many things in bariatric surgery. We looked at the outcome of concomitant removal of gastric band to gastric bypass to sleeve gastrectomy. We examined also the concomitant hiatal hernia repair versus sleeve gastrectomy, and I found the use of this registry extremely helpful. This is one of the papers, for example, when we looked at concomitant removal of gastric band and sleeve gastrectomy, and concluded that there's a slightly higher risk of sepsis. The NSQIP had limitations. The complications listed were not procedure specific, so they not included bariatric surgery, for example, the complications such as leak, staple line leak, etc. The pre-op variables were also not disease specific at the time. And that was what led to the development of a more bariatric surgery specific database, which is the MBSQIP, which is widely used now in the United States. So there are other registries besides the MBSQIP, the Swedish or the Scandinavian registry, the British obesity metabolic registry powered by Dendrite, and Dendrite is widely used now. I know our colleagues in Kuwait are using Dendrite, and many other hospitals in the MENA region are using the Dendrite system. So that's a very important step forward in establishing registries in the MENA region and understanding better our outcomes. This is an example from a study from the German registry where they examined gastric band removal, one step versus two steps. And you can see here, when you have a bariatric specific registry, you can actually better understand what happens. Comparing 5,400 primary sleeve gastrectomy, 137 one-step approach versus 37 two-step approaches. And you can see that there's a higher operative time in the one-step approach. But when examining the risk of leakage from the staple line, the one-step approach was significantly more risky. We used the NSQIP database to examine the safety of concomitant sleeve gastrectomy with cholecystectomy, and we noticed that there was a slightly higher rate of adverse events, particularly pneumonias. However, when you compare that to a study published using the Scandinavian Obesity Registry, which is a far more elaborate and sophisticated registry, you can actually start to get more meaningful data. This is a paper examining the morbidity of cholecystectomy and gastric bypass in the national database. And this was using two registries, one, the Swedish registry for cholecystectomy in ERCP, and the Scandinavian Obesity Surgery Registry. And the conclusion was that there was a higher aggregate complication when cholecystectomy was performed after Roux-en-Y gastric bypass rather than before. And furthermore, there was an increased complication risk when cholecystectomy was performed at the same time of Roux-en-Y gastric bypass. In addition, simultaneous cholecystectomy added 61 minutes. So using these data can give you powerful information. So I'd like to conclude by saying that knowledge is power. Registries, databases give surgeons data to track their outcomes, identify areas of weakness that can help to improvement. The data collected prospectively should be disease and specialty specific for meaningful interpretation of data. With advancement of technology and computation, big data can be analyzed, incorporating patient-reported outcomes, DNA study, physiological data, etc. And finally, I would like to thank the scientific committee of Ifso Menac chapter for the excellent work they are doing. I would also like to thank Ethicon, Johnson & Johnson for their generous contribution.
Dear colleagues, friends, and members of the International Federation, I'm glad to navigate you through the empowering research meeting. While you are already informed about how research studies, data results, and questions reviewing a scientific paper are on your radar. However, before I start, I have to disclose that aside of being an active practicing surgeon in Austria and Dubai, UAE, I'm acting as consultant chief medical officer for Johnson & Johnson Middle East. Aside that, training and publishing and science is one of my biggest interests. According to the Ifso rules and regulations about case mix disclosure, I would like to disclose that the majority of my procedures are Roux-en-Y gastric bypass. So usually when it comes to scientific topics, you will ask yourself, why should I do research? Why is it so important to have evidence? And what do I want to achieve? What do I want to talk about? What do I want to have on a result for my patients? So that will then give you the navigation and the pathway how you might achieve that. And that is basically my topic for today. So you will not get your information on the internet, because internet doesn't make people smarter. It's quite the opposite. It just spreads stupidity faster. And this quote from Professor Lipham, US, I really love, because we should rely on evidence. We should rely on evidence because it demonstrates the improvement in outcome and quality of care, and it adds value to our treatment. It will maintain our up-to-date knowledge by using up-to-date studies, because when you are doing studies, when you are publishing, you are permanently confronted and related to up-to-date studies. That, at the end of the day, will build credibility and become also a credibility, because you, as a healthcare professional and as a trusted center, in addition to an advisor for approved treatments. So how can you generate your evidence? Which possibilities? I think Professor Safadi already mentioned a lot of those details. But when it comes to value-based healthcare assessment, that's the basis where you have to see institutional settings, you publish patients' pathway related to their outcomes. Another part would be outcome-based contracts, for instance, where payments with industry might be based on achievement that you agreed with defined outcomes. Then is very often mentioned investigator-initiated study. That is basically a clinical study initiated by an independent investigator and funded by the industry, that went through an investigator-initiated study committee and will be completely independent from the industry, just funded and financed. The next would be a clinical research study, which is initiated, led, and managed by you as a clinical researcher, as a department, or some hospital and universities do have clinical research departments. And then, in addition, you might heard from clinical registries, where usually big numbers of patients' data, often from a society or from a national level or from a national society, are put in a big database. That might lead and led to a real-world evidence study, which is usually done retrospectively on a situation, on a real-life situation, on the existing data sets that are coming from hospitals, from registries, etc. So what is really on a high scientific impact, you see it's basically a clinical research study that has the highest impact. But on the other hand, that is one of the most complex procedures that will be performed. As this is a recorded presentation, you may review it in detail later on. And in addition, I'm sure that you are already very familiar about research, which is very often an inventory when it comes to observational studies. which gives you the possibility I describe or I analyze. But in principle, every company is doing that every year. How many procedures we did, how many complications we had, how many products we sold, etc. This is something which is, let's say, very low on evidence. Much more evident might be controlled studies or non-controlled study, but that are prospectively done, randomized or non-randomized, or in form of a crossover study. So when it comes to, let's say, a practical evidence, a practical study that you might do, case control studies are very useful sometimes, where you study rare conditions with a long interval in between the exposure and the outcome, or cohort studies that are very often clinical and epidemiological research on a longitudinal observational study. The advantage is that it is, let's say, the biggest single problem of this when the design of the investigation is lost by the valuable information due to the loss of follow-up. The data are gathered usually prospectively. Time and relationship are clear, and the bias can occur if there is an unequal surveillance of subjects. And the subjects also may change their behavior over time. So case control studies and cohort studies might be very challenging, but on the other hand, very, very feasible. As I give you as an example, which I did publish very recently this year, a prospective pilot study on super obese with a banded one anastomosis gastric bypass procedure. So that is, for instance, where even with small numbers of patients, you can do a very, very interesting and let's say also high-ranked publications. I do not want to dive in deep in the phases of clinical research, because you are now very familiar in the COVID phase that until you bring up a product to the market, it has to run through a lot of phases until it is really approved by the government or by other governmental institutions. So my topic might be also the consideration for strong research, which I face that journal will be most interested on the highest quality of evidence. So I'm sure that you have heard on the Oxford Center of Evidence-Based Medicine levels of evidence, where you say the systematic review might have the highest evidence. But I would like to focus a little bit more and dive in on the strength and on the limitations. Let's say you are talking on the highest evidence level, which is a systematic review and meta-analysis of prospective studies. But that is that usually the articles may lead to a fragmented and incomplete data. They may not be consistent all over through the studies. And in addition, the publisher may really pick cherries as an example for the favorable hypothesis. So it is mentioned even in the New England Journal of Medicine that meta-analysis can be biased by the author. The strength of a randomized controlled trial is practically ideal for testing efficacy. The randomization reduces bias of the author, but however, there are possibility of biased randomized controlled trials. So randomization facilitates also statistically analysis. The limitation might be that it could come to ethical issues and ethical problems. It could be very expensive sometimes and also very time consuming, sometimes also by the facilitation of the statisticians And the statistical analysis, you need large number of participants and sometimes also a length of the study. So cohort studies, as mentioned, are quite easier and cheaper to conduct as randomized controlled trials, as you have seen what I recently published. But on the other hand, it's really a risk of bias. And it's very often non-randomized. The size and the cohort of the follow-up are important and really determines the level of the evidence. Case control studies, case series, single case reports, those are all evidence on the grade C and D. When it comes to registrations and registries, usually you don't have really control on patients' inclusion criteria. Trials are use specific patient selection, which does not necessarily reflect the real world situation. Very often it's called real world evidence, but it is sometimes only a collection of data from registries, a collection from hospitals' data. So that may not include very often clinical relevant outcomes, such as patient satisfaction or patient's details, treatment or cost. And then let's say, the latest or the least quality of evidence is expert opinion or our expert opinion. That's really a good source to understand the topic. But expert opinions and editorials are very often without critical appraisals or are based on limited experience. And one of the best is, for instance, the COVID-19 pandemic, where Anthony Fauci, really one of the, let's say, most dedicated experts, gave several editorials and expert opinion. But not all experts are really, let's say, agreeing to his opinion. So that is basically even published in a high-ranked journal, not always, let's say, uniform appearance and, let's say, a meaning that is undivided. So when it comes to your journal, where shall I publish? There are at the moment more than 400 surgical scientific journals with different impact factors. And one of the, let's say, criticism might be that the value of a lesser impact factor as a source of negative and inconclusive outcome published in Annals of Surgery, they concluded that very often the practice of focusing disproportionately on the positive outcomes of most studies may result in an unbalanced evidence. And very often also commercial bias may further complicate this balance. As you will see very often, industry supported or industry published data are very often in, let's say, lesser impact factor published journals. So what is the practical outcome? What is the practical conclusion when it comes to that topic of empowering evidence? If you review all the key points of your thought of study and you think about how you might communicate this clinical significance, if there is, and also you will prepare answers to possible objections, because when it comes to the conversation with ethics committee, when it comes to conversation with, let's say, institutional review boards where you want to apply for a financial support, it is extremely interesting also to think about what other institutions, other review boards may think about your study. So what is the question of the paper that you try to answer? Is the question relevant, important? How will you maneuver your study to answering it? And what might be the answer? Can your answer be really trusted? And what's about the ethics committee? How might you finance? And is it, let's say, a possibility that you get industry or, let's say, a scientific support from a society, or even financial support from government or from societies? So that is, let's say, my conclusion when you say what will be the publication status of the study. So I wish you, let's say, a great success with your idea, with your onset, and of course I will be pleased to respond to further questions, and would be absolutely great to. It would be absolutely great to discuss with you this quite very important topic on evidence in Middle East and North Africa. Thank you so much.
Thank you very much, Professor Safadi and Professor Miller, for your valuable presentation. So I'd like to start by a question to Professor Safadi. Practically speaking, how can applicants today who are interested to start a research start by applying their ideas, and what are the eligibility requirements?
Great. Something that was not well mentioned in my presentation is that the Ifso Menac has a research grant now. I think by now most Ifso Menac members know that we have a grant that's generally supported by Johnson & Johnson. It's in the value of $20,000 per year for 2 years. So this grant is reviewed by the Ifso Menac Chapter Scientific Committee, led now by Dr. Ashraf Haddad, and it's based on a competitive scale. So we encourage all the members to apply. Obviously, we'd like to support trials, clinical trials, like randomized prospective clinical trials. But like I mentioned from the talk, I was trying to allude to the fact that our infrastructure is relatively poor compared to that established in other countries, particularly in Europe and Northern America. Because to build research, you need, decades and centuries of culture bringing, which is now happening in the Middle East. So an easy way to start, I think, for all of us is to start with our registries, because they're already built, they're already available. There is an investment that we can put in the beginning, but it's a relatively small investment. Once we have access to data and numbers, that we can start examining them. That is probably the easiest form of research that can be done. I do agree with Dr. Miller that this particular research has a lot of caveats and kind of deficiencies, but I think that's kind of how I would recommend researchers to start.
Yeah, thank you, Basim. I think you focused very, very well and explicitly to data registry, importance on data collection. There's absolutely no out of discussion, no way that registries are extremely important. I mentioned this, that every company has a registry. How many products I sell, how many products I get back, how much I got. So this is something, the basis of, from my point of view, that's not science.
Professor
Charlie,
Miller,
we lost you. We cannot hear you.
Is working.
We can hear you now.
You cannot hear me? You can hear me now? Okay. Thank you, Basim, for your great overview, and especially to focus on registries.
I mentioned that a registry is something that every company, every hospital, everyone should have. How many patients are operated? What was the outcome? That is something which we should emphasize from a society, that everyone should put in data, because that should be the first rule of all. But that is, from my point of view, not science. Science is something where I have a specific question that I prospectively want to answer with a study. And usually the weakness very often of registries is who is putting in the data, what's the quality of the data. And just give you the example of the MBS WIP, where they have over 130,000 bariatric patients on sleeve gastrectomy, and the leak rate is 0.8. You look on prospective studies, you want to prove something, and the leak rate is 1.5 or 2%. So it is sometimes very difficult with a retrospective, with a database, to answer questions. And I think what you raised perfectly is that the Ifso Menac Society is engaging surgeons to bring up their ideas, to write a manuscript, to write an abstract. This is what I want to study, because from our younger surgeon will come the idea, will come the spirit of, I want to know something. And yes, the database, I fully agree, is a homework that everyone has to do. And therefore, we really should again emphasize that the Ifso Menac has a budget, thanks to Johnson & Johnson, where we can support young scientists and to support also and help also on governmental support. So if, for instance, that is really a very crucial, an interesting study, a very basic one that is coming from Middle East, which is as you mentioned perfectly, a different region, different social, different population, lifestyle, etc. So I think we really need from that region very basic studies also. And I would like to ask our auditorium if there are any questions or, let's say, ideas that you want to share within this short time. And thank you, Faisal, for raising up that possibility, giving the chance to focus on the need and the necessity in this region to do studies and to do research.
Thank you very much, Professor Miller and Professor Safadi. Actually, there is a question. So the research grant program is now open and available on a competitive basis for all Ifso Menac member. Professor Safadi, is there any deadline from the Scientific and Research Committee for the submissions? And the other thing is, any particular selection criteria that could be highlighted that the committee will consider for the winner?
Yes, I don't know if Dr. Ashraf Haddad is with us. I just sent him a message. Hopefully he can, we can have him tune in, because I handed him over the baton a few months ago. So I'm no longer in charge of the grant. I know that we've extended the grant deadline quite a while. We've extended it now for almost a year, and we've received, I think, at least 4 applications. I think the feeling was that we should extend it a little bit more so we can encourage more researchers to apply. Again, there's a rating for the grant, and as you go from level 1 evidence further down, your scores drop. So the emphasis would be on the quality of the care, whether it's a randomized prospective clinical trial, on originality, if it's answering something that is new and relevant. And also there's some part to the credibility of the institution and the researcher, i.e. the previous experience. So Dr. Haddad and his team has done a beautiful job in organizing them. And in order to make this transparent, we've also included reviewers who are non-biased, who are not part of the Ifso Menac community, to add more credibility to the review. So we wish the contestants the best of luck. Again, thank you, Johnson & Johnson. It's great to see this kind of support. I think I do agree with Dr. Miller that we have to start by instilling the culture of asking questions and trying to figure out the solution or the answer in a scientific manner. And hopefully we'll be able to see next year in the same meeting the presentation of the researchers who won the contest.
Thank you very much, Professor Safadi. Thank you very much, Professor Muller. We genuinely believe there is a huge opportunity that we synergize our efforts as industry and as society to encourage research and encourage evidence-based medicine. So with that, I'd like to thank you very much for your valuable time.
Thank you, and we'll see you tomorrow, the same time, same place, same venue, and look forward. This was a great first day. It's great to see our colleagues, even though we're seeing them remotely, and hopefully we'll meet next year without Corona.
Face to face. Thank you.
Good night.